we realized that throughout the 5 years period, we consistently achieved our minimum targets. For proportion of cases that were notified to the system, it was only in 2022 when we achieved the 80% target, but all the other years we were not able to achieve the targets. For proportion of cases that were investigated within 48 hours after notification, and the cases with 2 specimens collected 24 hours apart, we consistently achieved these targets. For proportion of cases with 2 specimens arriving at the lab in good condition, we consistently achieved it except for 2022. And the proportion of cases with 2 adequate 2 samples collected, we consistently achieved this with an average of 84%. However, in 2020, we were not able to achieve this target. And for proportion of AFP cases followed up for 60 days after paralysis and the samples arriving in the WHO lab within 3 days, these were the 2 indicators we did not achieve consistently. Because non-analyzed AFP rate is one of the key performance indicators monitored by WHO, we went further to do analysis by district. And we realized that only 2 districts, including Bo district and Falaba district, were not able to achieve the 3 per 100,000 population. And stools adequacy being another key indicator, we analyzed it by district, and we observed that 5 districts were not able to achieve the minimum target, which included Bonds district, Kono district, Tonkolili Western Area Urban, and Rural districts. From these findings, we observed that the country exceeded the targets for 6 out of the 9 WHO performance indicators, and this could likely be due to the capacities we gained during and after the Ebola outbreak and the CVD-P2 outbreak in December 2020. We also observed that targets were achieved for targets were not achieved for case notification, 60 days follow-ups, and sample movement to WHO lab. This indicates this is due to the ineffective community-based surveillance system in Sierra Leone, poor feedback mechanisms, and inadequate support for 60 days follow-up, and the unavailability of WHO accredited lab in the country. And this implies the possibility of missing cases of poliomyelitis. And if this continues, it is likely that we will meet the target of eradication. We also observed that the highest incidence of AFP was recorded in 2021 and in Kono district, which could likely be due to enhanced surveillance during the outbreak, and the Avada project that was implemented, in which Kono district was one of the districts. And 7 of the districts reported CVD-PV outbreaks, which could be due to low immunity and compromised vaccine quality, and the delayed introduction of IPV after the withdrawal of TOPV. We therefore concluded that our overall incidence was high, especially in 2021 in Kono district, and the country recorded an outbreak of CVD-PV2, which 7 districts were affected, and 6 of the 9 indicators were achieved. After these investigations, these were the public actions. We shared our findings with the surveillance program. We conducted training for districts that were poorly performing. We have prioritized those poor performing districts for enhanced surveillance. We therefore recommend to the Ministry of Health to enhance community-based surveillance in Sierra Leone, support district to low performance, and strengthen sample movement to WHO accredited lab, and for the EPI program to intensify OPV and IPV vaccination activities to improve coverage. These were our references. We acknowledge the following institutions. Thank you.
Without delay, let's go to Mirel. And Saidoba, are you ready after this immediately?
Don't know. This. This to advance. Prenez-vous. Yes. Bonjour à tous. Je m'appelle Mireille Elongo.
Todos. Chamo-me Mireille Elongo.
Le sujet s'intitule
The
de poliomyélite dans la
break in the Matthew Kibombo, Bulindo, Munyega.
Congo. Notre plan se présente de la manière suivante.
Dans sa présentation,
Introduction, nous disons que la poliomyélite
introdução, nós aqui mencionamos que o pólio é uma doença de alta infecção,
directement, soit indirectement,
or indirectly through use of contaminated materials. These children of below 5 years are the most touched. Then we have the strains of polio that have mutated from the initial strain originally detected through and vaccinated against through oral vaccine. In 1998, we had a call for reduction of polio incidences across the world. Since November 2011, DRC was declared as a free country from polio. It was until 2017 where the Democratic Republic of the Congo started registering cases of polio from the vaccine-based strain. 58 health areas were affected by this outbreak. Among them Kibombo and Manyema, which were areas that were affected by this outbreak. 2nd April, the health department was alerted of the paralysis polio, and after that we identified 18 suspected cases, 18 paralysis cases, high paralysis cases that were declared during this study period. Our objective was, general objective was to investigate on the case of cases of polio in the health areas, particularly confirm positively or otherwise the cases, and describe in place and time the people, and get samples for biological confirmation, identify risk factors, and put in place public health measures for controls. This is the map of the health region in which we carried out our study. So the population is 126,000 inhabitants, 12 health areas, and 7 health villages. Our study is a descriptive cross-sectional study covering all the cases of polio from the strain that circulates through oral vaccination over the period of study. The mode of identification of cases was through research, and passive and active research in the community and various health centers. The technique was, the data collection was through complete document analysis. We looked at medical records, patient files and case notification details, as well as identification of cases. The criteria of definition with regard to polio was defined as a case of polio which was children of less than 15 years manifesting acute paralysis, or all persons, or whatever their age, but with a paralysis which a clinician suspected polio. With regard to the confirmed case, those were all cases that were suspected with a biological confirmation. With regard to treatment and data analysis, the data was coded and analyzed through Excel and subjected to Starter 15, and the data was presented through tables and graphs. The samples, we had 2 samples per case, and these was drawn from persons or cases that had developed paralysis in the first 14 days, and these samples were sent for analysis at laboratories. With regard to the results, we presented our results. Our first graph here shows the epidemiological graph for polio cases. We have the number of cases, and on the x-axis we have the epidemiological week, and we see that we had a peak of cases after the 18th week, where we diagnosed 4 cases. Coming to the spread of CDVP cases, the socio-demographic characteristics, we had age. The age below 5 years were the highest effect, with and the female were male were highly affected, with 61% of the cases. Children who were either partially or less vaccinated had 7.8 or 30.8%. With regard to clinical symptoms, we noted fever, which was represented by 100% of the patients diagnosed. Fever had 53% of the cases, and paralysis, as we noted, we had paralysis of more than 2 members in the 69% of the cases. Talking about the accumulated vaccination coverage, on with regard to that, we noted that only one health area had surpassed the objective, which was 91%, and the other areas were below the target objective. In the discussion, we are pointing out that female were the most affected, with 8 cases on 13, and that sex becomes a risk factor when we are looking at the Kibombo Health Center. The ground was favorable, and we noted that most of the cases that were notified were either partially vaccinated or not vaccinated at all. In conclusion, polio constitutes and remains a major problem in Kibombo Health region. The outbreak of polio from oral vaccination was confirmed, and control measures were put in place. Enhancement of routine vaccination and sensitization of the community on hygiene measures could contribute highly and quickly interrupt the transmission chain of this disease. This is a photo when we were on the ground collecting data in one of the health areas. This is the photo I've just talked to you about, where we were collecting data in one of the health areas, and this is one of the photos that shows the daily mapping through vaccination in Kibombo health area. These are our references. So with that, we want to thank you for your kind attention.
OK. Merci beaucoup. Je suis Dr Saïdouba Touré de la Guinée. J'ai l'honneur de vous présenter notre sujet d'étude portant sur le profil épidémiologique des cas de paralysie flash aiguë dans le dispensaire de Bofa 2017-2021. Pour ce faire, notre plan de présentation est le suivant. En effet, la paralysie flash aiguë est une infection irréversible due au virus coronavirus.
Critical infection touching or affecting children of less than 5 years. This, we have 7 to 14 days of incubation period. From the start of this, a number of commitments were made leading to a reduction of the cases of polio. Up to now, Pakistan and Afghanistan are the countries that are still notifying of cases of polio through vaccination. Africa has been free from polio in 2020. Unfortunately, in 2022, the cases of vaccination polio were declared in Malawi, close to the strains in in 2020, 9 cases of polio were vaccinal polio were notified in Bofa. The district of Bofa is a district, a health district that is densely populated, and all the health structures are involved in surveillance of polio, especially through definition of cases. Bofa is a great influence area because it hosts mining activities. However, no analysis has been done in terms of the profile of polio, and this led us to propose this study and get the epidemiological profile of polio cases and evaluate the quality of data for the surveillance of polio. Sorry, he's simply reading through. We can't keep up with his pace. In this case, in 2027 to 2021, we did a study where children were identified. We had cases of notification of polio. Data was collected and presented as frequencies, tables, and graphs. In this study, we included children where the cases of polio were notified through DHS2 in Bofa. All those who met these criteria were who did not meet this criteria were excluded. The demographic characteristics and laboratories were the key variables. The percentage of children were picked for cases of paralysis, as well as the presentation of samples picked and taken to laboratories. This method allowed us to have a total of 23 cases of polio. Among them, 600 items were to be filled as details, and among them we had 7.3% of missing data. We did not have any incoherent data. Of the cases of polio noted, we had samples tested in the laboratories from vaccination polio. Fortunately, we did not have deaths. The symptoms were essentially paralysis and fever. These cases had an age of about between 3 and 13 years. Men were the most represented. With regard to vaccination, 8 children had not been vaccinated for the 23 cases for the 3 doses. In terms of the spread across various administrative areas, we had some administrative areas that had not had vaccination for more than 5 years. However, the cases of polio for children of less than 11 years had been investigated over the 3 years with key indicators for surveillance of polio. The key indicator and there were samples that were put to the laboratories for testing 3 days after. Our data analysis in our results showed that most of the cases presented paralysis, and these results are similar by those done by other studies in Mauritania. The age bracket of less than 5 years was the most represented. 3/4 of the cases and half of those were not vaccinated. The total number of samples were taken to the lab in Conakry 4 days after the first extraction of samples, and for that period we have been able over 4 years to eliminate polio. The parameters would compromising the quality of the study were missing data, but however this did not affect the quality of the results. We had some medical centers that had not been operational for a long period of about 3 to 4 years. Generally, we can say that the data of surveillance were of good quality. We had a weak or a low proportion of missing data, and the case of 2017-22 indicated that children of less than 5 years were the highly affected in cases of non-vaccination. The surveillance covered most of our administrative areas in 14 days following the detection. We have other administrative areas that did not notify of cases. Others had a communication plan that was put in place for sensitization, involving all the actors involved in surveillance of polio, and the impact of this communication or sensitization led to 2022 having all the health centers that had notified of cases of polio. With this, we recommend an enhancement of surveillance at the community level and implement a good plan to reach out every child in all the districts especially in the cases of health centers that notify the centers. We thank all the entities that collaborated with us. Thank you very much. We are sorry for the pace of the presentation. We couldn't cope with it at all. Thank you.
We are remaining with one presentation from Yemen, but the presenter is not here. So in that case, we have come to the end of our presentations, and now we are going to take questions. Hope you have noted your questions. People have been sitting down, listening. Please let us stand up and stretch a little bit. And prepare your question.
S'il vous plaît.
Yes, let's take it. Okay. Yeah. We are going to take questions one by one. You raise up your hand. We'll pick you. Then you tell us your name, where you are from, and who are you directing your question to. And let's start here.
Thank you. Merci.
Thank you. I thank the three presenters for the quality, the four presenters for the quality of their presentations. However, the topic was of great interest, and I have some questions to ask. I am Yaya Balaira. I am an epidemiologist doctor working on polio. I work with AFENET based in Kampala, but I'm from Mali. I have a question for the first presenter, Fraser. She gave a case definition which does not, in my opinion, cover the entirety of the persons that would develop polio. I would want to know, because in her case definition, she was very precise, children of less than 15 years or below 15 years. Why children, only children of less than 15 years? Another important item she insisted on is contact follow-up for the cases of polio or PFA. They followed the contacts. I want to know what were these contact cases, how were they defined, and they were followed for how long with regard to the date of the start of the paralysis. She also talked of screening for the new cases, the new arrivals at the refugee camps who are screened. I would want to know how was this screening done? I think that is all for Dr. Fraser. Thank you.
That. Let's go to another question. Please give him the mic.
Thank you so much. I am Dr. Chala Abalo Agbala from Togo, and I'm working with AFENET in Guinea as the field coordinator of Guinea FLTP. Congratulations to all presenters. The question I have is first for the first presenter. I want to know about the environmental surveillance for polio in Kenya. Is it conducted? If it is conducted, is there some findings you can share with us in the area where you conducted your study. Secondly, my second question is about the case definition. You talk about the lay case definition, and I think it was about community health workers. And I think the introduction of the criteria about injury in the case definition may miss to detect AFP case definition, because normally community health workers have to detect and notify all cases which have sign that resemble to AFP cases, and his supervisor has to come and verify to validate or reject as a validated AFP cases. The second presenter which is concerned by, who is concerned by the question I have, is Dr. Mireille, I think from GRC. I want to know the contribution of community health workers in the study that she has represented, particularly in the detection and the notification of AFP cases. The second comment is about the coverage of OPV vaccine that she has presented. Is it a result of a survey, or is a result of a desk review? Thank you so much.
Good morning, everybody. We are very happy, to your presentation. Really, I am come from Somaliland. My name is Dr. Nakruma. I work in, the cross-border. The other, the French, I think is far as, but just I can ask, the Kenya, because they consign us for the cross-border, the DAB area, the Garissa. The question is, for example, the case when you see in the camp, how far the communicate the other area of the cross border, because maybe the other side of the coming, the inside of Somalia, or that maybe there is more cases like that. Secondly, for example, if I give you our cross border now, there is some area in Kenya, Ethiopia, like that. There is some committee in the cross border. If you have that committee also, please, because it's very important us. Because many times there is the cross border moving to the Kenya like that and how to collaborate that committee if they have. Thank you very much.
Thank you.
Good morning. I'm Amara Alhaji Sharif from Sierra Leone. I'm working with AFENET on the Sierra Leone Field Epidemic Training Program as a mentor. My first question goes to the first presenter. In your definition of a new arrival, I did not see any time factor there. And I know here you have refugees that have stayed for years in Kenya, but your definition was just on those who came from other countries, and there was no time factor. So I'm wondering whether everybody in the camp we are considered as new arrivals. And my second question goes to Andrew from Sierra Leone. You mentioned that the capacity you gained from Ebola and the CVD PV2 capacitated you to do your case search. So I really want you to expand on that. How does experience from Ebola and the CVD PV2 can contribute to that?
Okay, merci beaucoup, Monsieur le Président.
Thank you very much. I will speak in French. I'm not good in English. I just want to bring out a general observation with regard to the identification of CPVD2. Actually, at the moment, we need to talk of a polio variant that is of circulating type 2. I don't know. I work with AFENET, and at the same time, I am a consultant with WHO Mali. I mean to say that I work in the area of polio, and I'm very keen on the names given. I have a question to address to Andrew. During his presentation, I noted that in 2002, actually in 2021, with regard to polio notification within a deadline of 7 days, from 10% and to 80%. I wanted to know the strategy they put in place to increase that notification with regard to that indicator. For the second presenter, Mireille, I am concerned about the epidemiological curve that she presented. I think it needs improvement. This should be presented as a histogram without spacing and not the way she presented. Regarding the last presenter, I want to mention something about his results. He said that all the health centers had notified polio cases. I think that is a slip of the tongue. I don't think it is polio that was notified in all the health centers. He may want to come back and clarify that. Thank you.
Please put your hand down. Let us answer these questions first, and then we'll have another round. I think Wanjiko has 4 questions, Andrew has 2 questions, and Mirel also 2 questions, and there is 1 question for Saiduba. So Mirel, take the floor, please. Thank you.
Thank you very much to our panelists. Thank you for the questions. I will attempt to answer some of the questions, and the one that it's not so clear, we will discuss with the concerned person. So the first question was on the case definition, and he asked why children over 15-year-old, and my case definition for the suspected case, I say that it is any case with weakness of floppiness of sudden onset, not due to trauma, in children under 15 years of age, 15 years of age, or any person of any age in whom a clinician suspects polio. So we say it is 15 years old, but we are not limited to the 15-year-old. We are saying that of any age, because we know polio can affect any age, but again, we are saying that it is anyone that the clinician suspects. So we are not limited only to the under 15, but it is opened to any age. But as the case definition says in the suspected case, it is 15 years of age or any person of any age in whom a clinician suspects polio. And maybe I'll look for more clarification on the case definition. He also asked about the 3 contacts that I said that we followed up. For every index case, we do a 3 contact follow-up. And these 3 contacts, he asked who they were. And this child who had developed paralysis was from Somalia. She was hosted in Kenya in the refugee camp by that family. That family, one of the contacts is that the child of that family was an under 5. So the first contact was under 5 of the hosting family. The two other contacts were from the neighboring households where these children came to this hosting family and interacted with the index case. So there were 3 contacts. One was from that household and the other 2 was from the neighboring household. How long we followed up? We did a 60 days follow-up for these 3 children that we did the contact follow-up for them. Then there is another question that came up. How was screening done for the new arrivals? In Kenya, in the refugee camp, when we have a new arrival, we have structures. The community, our president launched the bottom-up approach, and we are using the community health promoters to be able to follow up on this new arrival. So each block, those refugee camps have blocks, and in those blocks, they are assigned community health promoters. Anytime we have a new arrival, this community health promoter, who is in charge of 100 households, is able to go to that particular house, and then they check at these new arrivals, they check at their vaccination status, and if these children are 0 doses, they are able to take them to the nearest health facility. And that's why this child was easily identified. The child arrived on 21st June, and the community health promoter was able to identify this child on 22nd of June because of the structures that we have put in place in the refugee camp to be able to identify the new arrivals. Then to the other question, I was asked about the environmental surveillance. How is it conducted in Kenya, and is it funded? Yes, environmental surveillance in Kenya is conducted routinely. It's part of the surveillance work that we usually do. We have around 6 environmental sites, and this is complementary to the acute flaccid paralysis surveillance. So it is complementary to be able to do this environmental surveillance. It is not, I cannot really say that it is fully funded because we are relying on the partner. The local government or the county government is not funding that work, but we are relying on the partner, especially the WHO, who supports AFP surveillance in Kenya. So it is, I can say that it is funded, but not by the local government. It is funded by the partner who supports the AFP surveillance in Kenya. And then on the case definition, for the lay case definition, yes, somebody raised a concern that it might miss out somebody. We say lay because it is used by people who are community health promoters, and they may not have the right technical know-how to be able to know all those technical or the jargon. So that's why we put it as lay as possible. And my lay case definition for the CHP, I say that it is what they look out when they go to the field, it is any child who develops sudden weakness or paralysis in the legs and arms and not caused by injury. So the only work of this community health promoter is to identify when they go for their household visit and they identify any child who has paralysis, like this community health promoter. I went to the household where this child was hosted, and then he noticed that this child has paralysis of the limb, and then their work is to notify the health facility. So their work is not to treat, it is just to notify the health facility that I found this child, and this child has paralysis. Then on how do we communicate on the other side of between Kenya and Somalia is that we have a cross-border committee. In the Division of Disease Surveillance and Response, we have a coordinator of cross-border committee, and this person is the one who is in charge of cross-border activities between Kenya and Somalia. We also have a partner in Kenya who is supporting the cross-border committee or cross-border meeting. This partner is called the core group partner. So they're the ones who are in charge of supporting these activities in in the cross-border. For the new arrivals, yes, it is true, it did not have a time factor. I searched through the UNCHR, the ones that are responsible for the refugees, and initially I had asked them, and they said that initially they used to say that the time factor is 1 month for any new arrival in Kenya for around 1 month. But they opened it up because they said that you can be in 1 month in Kenya, but yet you are not registered registered in their registers. So they opened up. It doesn't have a time factor, but I'll still continue looking for more research to see whether if there is any time factor. But for now, we are not putting any time factor on it. So thank you so much. I believe we will interact with people as we continue. Thank you.
Thank you very much. Let's go to the next. Let's go to. Okay, Mirel, you are set. That's fine.
Je tenais à vous remercier.
Thank you very much for the keenness you have shown in my presentation. I'll proceed to answer the questions that were asked. The first sought to know the contribution of community health workers in the notification and diagnosis of polio. The community health workers, in our place, we call them the community links. These are people who have activities done at the community level. They know case definitions with their definition of cases relating to the work that they do in households. They do home visits, and it's through the home visits that when they note cases, they note acute paralysis in the community, and they point that case to the health centers or hospitals. So that is how the community health workers contribute in the diagnosis and even detection of polio cases. Secondly, we talked about vaccine coverage. We sought to know whether this vaccination coverage we talked about was informed by investigations or documentary reviews. We wish to point out that during the study period, while we collected data on the ground, I am the head of that health region with regard to data, with regard to monitoring, monthly monitoring regions, monthly observations, data comes to us from the health areas up to our center. So briefly, these are data coming, these are secondary data from the health areas, because we mentioned that the method that we used was documentary review, where we looked at health consultation records, notification sheets, as well as reports from the health centers. Thank you.
So thank you very much to the audience for giving keen interest to my presentation and sharing your concerns and questions. I have 2 questions to respond to. I want to start with the last one that was asked by Dr. Kaita. Did I get the name right? All right. So you ask, how did we manage to improve the notification rates from 10% to 80%? I don't remember presenting that on the data. That could be on slide 15, that actually talks about the performance. In fact, case notification was one of the indicators we consistently performed low, except for 2022. I guess what you wanted to ask was, how did we manage to improve from 70% in 2021 to 81% in 2022, an increase of 10 or 11 percentage points? That was what you wanted to ask. So in 2021, there was a policy development on the training of community healthcare workers in Sierra Leone. Have a look at missing out on not only AFP reporting, but other surveillance diseases of interest where we are surveillancing in Sierra Leone. So in 2022, because of those training and implementation of the CHW program, the Community Healthcare Worker Program in Sierra Leone, with part of the package of the training being AFP surveillance, we saw an increase in the AFP notification rate. And we are hoping that is going to that is continuing in 2023, although my data analysis did not capture that, but it's already showing that it is giving a very positive dividend. So, Mr. Sheriff, so he asked, how does the capacities gained after the Ebola applied to AFP surveillance in Sierra Leone? Sierra Leone was one of the countries that was really very ravaged with the Ebola virus disease 2014, 2015. At that time, we had like a broken health system. Surveillance was very poor. It was not a priority. But just immediately after the AVD outbreak, with support from WHO and CDC, almost all our health facility staff, especially surveillance officers, were trained on integrated disease surveillance. And as part of the integrated disease surveillance, AVD was one of it, and AFP is very key to that. But one that has also contributed a lot to it is the training of almost all district surveillance officers in field epidemiology, supported by CDC and AFENET in Sierra Leone. So for now, it would be interest this audience to know that almost all our disease surveillance are trained and graduated, at least with frontline experience in FETP. So those ones have helped a lot to improve on the performance we have gained over the period. Thank you.
Merci, Monsieur le Modérateur. Merci à tout le monde.
Thank you, Session Chair. Thank you, Dr. Anin, for the question you asked. In our country, we have cases of polio that we sample as notified at the health centers. 3 days after notification, we get the sample and take them to the laboratories in Dakar for confirmation. Thank you.
We had really wanted to take another round of questions, but we have been alerted that we are over 30 minutes over time, and we need to leave the room for another session. So with this, I would like to thank everyone, our evaluators, our room manager, the IT, participants and the presenters for the excellent collaboration, and thank you very much. With this, we come to the end of our session. Bye-bye. We can give big clap to our presenters.
Second evaluator. Hello. Hello. Can we settle down to start the next session? Please. Let's settle down to start the next session. Is there? Yes. So every 5 minutes presentation, right? Okay, so can we get our presenters ready? Hey, what's the name? Gal Kwamen. Enyu Zeleke. Are the presenters here? Nobody? And then what's the name? Cisse, you are here? Oh, please come. EPSA Tarifa. It's not coming at all. Is it available? EPSA is around. Then the DESCO. Where's the DESCO? Ernest Mowa. Okay. So we have 3 out of 6. Girl Kwamen, not here. And Zeleke is also not here. Zeleke is supposed to be from Ethiopia. Is he available? Zeleke? It's not available. Okay. Then Cameroon. Kwamen is from Cameroon. Is he available? I have 3. Okay. I think it will save us some time. We have 45 minutes for this session for 6 people. So now that we are 3, it is reduced by 15 minutes. So try and do this in 30 minutes. So this is a session on poster, and it is still vaccine preventable diseases. So we're going to have and we don't have Cisse. Tarifa. So each person has 5 minutes to do the presentation. And then the poster session is 5 minutes according to my guideline for each person. So try as much as possible to go through the poster and give us the salient points. And then for all of us, we are expected to have our questions, and then at the end of the presentations, then we have 15 minutes to discuss or less, depending on how it goes. So if we are ready, we'll give the opportunity to Tarifa, to do your presentation.
Okay. Good morning, everyone. My first name is Makonnen, Ethiopian FLTP and Court 1 NCD track graduate, and currently working under Zonal Health Department in Amhara region. I am here to share our work on measles outbreak investigation in AFENET district, Amhara region, Ethiopia, March to April 2021. Measles is a contagious and vaccine preventable disease globally. By the end of 2020, about 84% of children received measles containing vaccine 1, and 70% of children received MCV2. However, about 90.8 million infants didn't receive MCV, with the majority in Africa. Also in Ethiopia, 95% of children received MCV1, and in Amhara region, 88% of children received MCV1. In March 2021, an outbreak was reported from AFENET district. Hence, it aims to investigate a measles outbreak in AFENET district, Amhara region, Ethiopia. We used descriptive cross-sectional and 1-to-2 unmatched case control study in AFENET district from March to April 2021, which is far from 254 kilometers from Bahar Dar city, which is the capital city of Amhara region. And we used primary data source through interview and observations, as well as secondary data source, line list and district, from the district data, DHIS database, to track the measles vaccine trend, as well as we use structure questionnaire, which is adapted from CDC outbreak investigation, and data was collected using EpiCollect 5. When it comes to case definitions, cases are those either suspected, which means fever plus macropapular rash plus at least one of 3C, cough, coryza, or conjunctivitis. The other one, laboratory confirmed, which means suspected case plus laboratory detection of the measles virus, as well as epidemiological linked to confirmed cases, and those are identified by case search. The other one, control, were selected randomly from the neighbors of cases. A total of 55 cases were detected. Among these, 6 were laboratorically confirmed, and the attack rate was 1.13%. Case fatality rate 5.3%. Among 55 cases, male contributors 31 or 56.4%, under 5 years 72.7%, and now about 92.7% were not vaccinated before, and 52.7% have contact history. The other one, MC1 dropout rate was in the Kabale 25.7, and MC1 to MC2 dropout rate was 22.7, and in the district, a total of 1,159 children. That means 33.5% were not vaccinated or dropout. This one is the attack rate of measles outbreak by age. As you see, under 1 years children were the highest have attack rates. And the index case was detected on 26 February at the private clinic. At that time, the health post was not functioning, and rumor not reported to the next level. The index case was detected on 26 February, but till the March 17, there was no case surveillance, and 2 samples were collected. Among those, 1 was confirmed, and 8 samples collected. On other day, 5 were confirmed. But the response was initiated lately. So, delay in case detection and reporting rate, lower vaccination rate, presence of travel and contact history are found to be the main contributor factor for the outbreak in the district. Therefore, implementation of the new global target, the 3 number 717, detection of cases within 7 days and reporting to the public authority within 1 day and initiating of response, effective response within 7 days, highly recommended. Also increase public awareness on the importance of measles supplementary immunization. I would like to acknowledge these individuals and organizations. If you have any further information, contact through email or telegram. Thank you.
Thank you very much. Thank you very much for doing it in 5 minutes. So our next presenter is it Tarifa? Okay, Tarifa is not here. Dedesco. Dedesco will be presenting on measles outbreak in Harper and Plivo districts, Maryland County, Liberia. So Dedesco, you have 5 minutes. The Dedesco's presentation. So whilst we wait to do that, we'll take presentation from Ernest Mawa. Ernest, your presentation is titled Measles Resurgence and Outbreak Investigation in Chimanimani districts. I hope I got it right, in the Zimbabwe. So you have 5 minutes for your presentation.
Ladies and gentlemen, a very good morning to you. I'm Ernest Mawa from Zimbabwe. I stand to present findings of our study entitled Measles Resurgence and Outbreak Investigation in Chimanimani District, Zimbabwe 2022. Measles is a vaccine-preventable disease. It is highly contagious with a 90% attack rate. Children that are unvaccinated, the under 5s, those that are malnourished are at risk of severe measles disease, including death. Chimanimani district was affected by the Cyclone Idai natural disaster in 2019 during the COVID-19 pandemic, and that resulted in disruption of the routine immunization and the supplementary immunization activities. And these World Health Organization. There were 5 laboratory confirmed IgM cases of measles in Chimanimani district that were reported week ending 17 July 2022. We therefore determined factors contributing to the resurgence of measles in Chimanimani district. We conducted a one-to-one unmatched case control study where a case was a Chimanimani district resident, less than 15 symptoms, or tested IgM positive between 6 August and 6 September 2022, whilst a control was a neighbor who did not have measles signs and symptoms. We recruited 126 and 126 controls and used interview-administered questionnaires, line lists, record review of cases to obtain information about the outbreak. We conducted a 5-year trend analysis of the district vaccination coverage, bivariate analysis, and logistic.
For the period 2018 to 2022, the measles rubella 1 and the measles rubella 2
coverages were both below the 95% district target. In addition, this was a propagated outbreak as shown in the epic curve. The vaccination campaign started late into the outbreak as shown in red from the 22nd of August 2022. The outbreak was declared over on the 6th of September 2022. The socio-demographic characteristics were comparable for gender and the caregiver level of education. The odds of contracting measles were 2.25 times higher for the under 5s than those above 5 years, whereas the odds of contracting measles were 4 times higher for unvaccinated children compared to those vaccinated. Furthermore, being from the apostolic religion was almost 3 times the odds of contracting measles than those non-apostolic. We therefore concluded that the measles outbreak was due to a combination of factors and events consisting of persistently low vaccination coverage over a period of time and a build-up of susceptible population. We recommended Chimanimani district to improve the epidemic preparedness, to increase coverage of the measles routine and supplemental immunizations to above 95% so as to achieve and sustain herd immunity. Public health actions that we undertook included innovative approaches targeting the vaccine objectors, and this comprised the use of unmarked vehicles for supplemental immunization activities and the recruitment of village health workers from the vaccine objectors to increase the vaccination coverage amongst the apostolic religion. Furthermore, there was engagement of the traditional leaders and the apostolic church leaders. Ladies and gentlemen, thank you.
Thank you very much. Thank you very much for the presentation and for keeping to time. So we are still resolving the presentation for the desk. We'll sort you out shortly. So whilst we do that, we would like to take questions for the first 2 presenters. They've talked about measles outbreak investigation and mentioned issues related to late detection, 717 application. Also, the second one was on a case control study, looked at issues related to the risk factors for measles in Zimbabwe. I want to see by hands those who have questions, then we can take. Okay, so I have 1, 2, and 3 for the first round. So first, please kindly be straight to the point, and then I can assure you that the presenter will also go straight to the point to answer your questions.
Okay, thank you. First of all, I would like to thank all the presenters for their brilliant presentation. The first question goes to Mekonnen, Ethiopia. We could notice that your case fatality rate is higher than usual. It was 5.3%. I would like to know why, through your investigation, did you get insight from what could be the cause? My second question goes to Ernest. In your case definition, has been limited to just children under 15 years old. I would like to know why. Thank you. Over.
Thank you very much for the presentation. My question is for Ernest. You said being an apostolic is a risk factor for being infected with measles. Is there anything among the apostolics that you think could have predisposed their children to getting measles? Thank you.
Yes, third.
Thank you. My question goes to the colleague from Ethiopia. So on the EpiCave, there is an indication that on 31 March there were cases. However, on 02 April, the EpiCave reflected that the outbreak had been controlled. I'm not sure why they could actually say it was controlled 3 days after. And also, they did not share information on whether he tested or he measured the association between the causes or to do the analytical study on which will give odds ratio, since this was a case control study. And also, I wanted to know whether COVID had an effect on the low performance of the low vaccine coverage. And also, I also have a question to Ernest to say what was the efficacy of MCV1 and MCV2. Thank you.
There's a question here first before we take the other one.
Okay. Thank you so much. My question is for the first presenter. In the case definitions, he has defined the case as any person with signs or symptoms or with measles antibodies. But for the control, he has only stated that it was any patient without any sign or symptom. And he didn't take into account the biological criteria as he did it for the case. So that may underestimate or should estimate the measure of association. Thank you.
Okay, last question for this set. Yes, please go ahead.
Oui, merci beaucoup. Ma question s'adresse à notre ami éthiopien sur la déclaration de la maladie. Entre les cas index et l'épidémie, il y a presque 10 jours. En 10 jours. Qu'est-ce qui a manqué au personnel de la santé pour déclarer l'épidémie? Il y a eu manque de sensibilisation du personnel ou bien il y a eu manque de matériel médical? Merci beaucoup.
Great. Okay, so we'll give the opportunity to the presenters to answer the questions, starting with you.
Okay, thank you for your questions and audiences. The first question.
La première question.
Was the outbreak was occurred in Kabale under AFENET district, which is hard to reach area. In that area, the health post was not functioning for more than 2 months due to one health extension worker on education, and the second one annual leave due to birth, and the health post was not functioning, and the patient didn't get treatment early, which is far from 66 kilometers from the district, as well as more than 40 kilometers from the health center. That resulted the case fatality rate was high. The other one, the outbreak controlled 3 days after investigation. I think the epi curve or the epidemic curve shows from index case to the outbreak control. We follow the outbreak for more than 1 month, and the outbreak was controlled. We say controlled after following for more than 1 month. The other one, the low vaccination coverage. This was mentioned before. The health due to the unfunctionality of the health post, the vaccine was not delivered for the eligible children, as well as the health post or the Kabale was the hard to reach area, which is far from the health post as well as the health centers, and inaccessible to get the vaccine timely, and they provide before through the outreach services. The other one, the reason for late detection, as I mentioned before, the index case was detected or in the private clinic, and that calling not reported for the public authority timely, and this results the late detection. Thank you.
Thank you for the question. Thank you for the questions. Thank you for the questions. Let's move to the side. Thank you for the questions. There was a question on the case definition that it was limited to 15 years. From the line list, the cases had age range of 15 years and below. Hence, we limited the case definition to those less than 15 years. And then the second question was being apostolic and what other practices predispose the children to contracting measles. So the apostolic sects, they were predominantly vaccine objectors, and some of their practices predisposed these children to contracting measles. If a child had measles, this child was mixed with other children in a hut where they were staying with the other children that did not have measles. And then there was another question on the measles containing vaccine 1 and vaccine 2, their efficacy. So the measles containing vaccine, the first one, there's an efficacy of 93%, whereas the second MCV has an efficacy of 97%. Therefore, children that have 0 doses or have 1 dose are at risk of contracting measles. And with the vaccination, there's lifelong immunity. Herd immunity is established, it's maintained. If 95% coverage is achieved for both the measles containing vaccine 1 and measles containing vaccine 2 coverages. The fourth question was on COVID. If the COVID had an impact on the vaccination coverage. Yes, with COVID, there were travel restrictions, and there were also staff shortages, and there were also weakened health systems, particularly for Chimanimani district, because at the same time that the COVID pandemic was raging, there had been a tropical cyclone Idai natural disaster, which resulted in destruction of health infrastructure and displacement of homes, disrupting the routine measles and supplemental immunization activities. Thank you.
Thank you very much. We are almost through. We have just 5 minutes left to close this session. Unfortunately, we have an issue with the DESCO's presentation. We'll give just one question, if anybody has one question to any of them. And if after this one question we don't get the DESCO's presentation, we'll have to add your presentation to another group, and then we'll inform you appropriately. If there are no questions, okay, just one last question, yes. That's just to wait for.
Okay. Okay, thank you. My name is Choga Godwin from Zimbabwe. It's not a new question, but to remind the one from Ethiopia about a question that he didn't answer in the first round. In the methods, he indicated that he conducted a cross-sectional study and then 1:2 unmatched case control study, but we did not see the results of the case control study part. Thank you.
Thank you for your questions. Yeah, I have, it is a report in the main document, but as the time is short, we present only the descriptive analysis and the identified factors. Thank you.
Okay, great. So thank you. Finally, I think we are resolving the issue for the DESCO. But I think we have learned quite a lot. We have measles vaccines, but we still get outbreaks, and it is important to know why we are getting outbreaks. And our colleagues are doing a lot of work in wherever they are to tell us the reasons why we still get outbreaks in spite of we having vaccines. The DESCO, your opportunity is now to present 5 minutes. Sorry for the inconvenience.
Good morning, everyone. My name is Didasco Gua, FETP graduate from Liberia. I will be taking you through the measles outbreak in Plivo and Harper districts, Maryland County, Liberia 2022. Measles is highly contagious. Measles vaccine averted 56 million deaths between 2000 and 2021 globally. In 2022, about 83% of the world's children receive one dose of measles vaccine by their first birthday through routine health services, which was a lower since 2008. As of 2021, only a dose of measles vaccine was given to children in Liberia to declare them immunized. Harper, Maryland County reported 81% of measles vaccine coverage in 2021, Harper contributing 81.5% and Plivo 79.5%. A community health worker in Maryland County reported 5 suspected cases of measles on February 2nd, 2022 from Plivo district. Our objective was to investigate, to verify the outbreak, to identify the source of the outbreak and implement control measures. Maryland County is one of the 15 counties in Liberia. During this outbreak, we define a suspected case as anyone from Harper and Plivo districts with measles, generalized rash, coryza, rare eyes, or anyone in whom a clinician suspects measles from January to February 2022. A confirmed case was defined as anyone whose measles was laboratorily confirmed or had epi-link with a confirmed case. Contact was anyone who stayed or played with a confirmed case. We conducted active surveillance. We identified and monitored contacts. We collected blood samples and analyzed our data descriptively and immunized eligible children in the affected communities. Of the total 321 suspect cases, 120 of them were confirmed. 20 was through the lab, and 100 of them were epi-linked. The median age group was 8. Female constituted 55% of the cases. 19% of our cases did not have vaccine history. The attack rate for Harper was 3% and 7% for Plebo district, respectively. Our index case was a 1-year-old female, a resident of Harper, who had no vaccination history or travel history. She had no contact with a confirmed case prior to onset of the disease. We vaccinated 79 children during our vaccination period. So this graph shows that 66 of our cases were females and constituted 55% of the total cases. The age group 1 to 5 constituted 55% of our cases as well. For vaccination starter, 97% or cases were vaccinated, constituting 80% of the total cases received. So 100% constituting 83% of our cases were epi-linked. This is the cluster map of the cases concentrated in the main cities in the both districts that were affected by the outbreak. So the source of the outbreak was not identified, which was contrary to similar outbreak investigation conducted in Ethiopia. Children vaccinated with measles vaccine were mostly affected. This was similar to another outbreak investigation conducted in. This was a confirmed measles outbreak in Plebo and Harper districts. The outbreak could be due to poor immunization. The source of the outbreak remains unknown. Vaccinated children were mostly affected. We therefore recommend to evaluate the measles vaccine program in the district, conduct further studies to establish why people vaccinated are still coming down. Dear colleagues, we therefore want to acknowledge the following institutions for their financial and technical support during this outbreak. Thank you very much.
So we have only 2 questions for the desk group. Only 2 questions. 1, any other? 2. Great.
Good morning, everyone. Thank you very much for the presentation. I have a question based on your findings and your conclusions. You presented findings that indicated that those who were vaccinated made up 80% of the cases. I am wondering whether they were fully vaccinated or partially vaccinated, because I think that would be very key in presenting whether or not this was 1 dose or 2 doses. And then again, on your conclusions, you concluded and recommended an assessment of the cold chain for the vaccination cold chain. I'm also wanting to know why you may have made that recommendation specifically. Thank you.
Oh, the same question. Okay. Okay, then that's fine.
Okay.
So let's take one last question for it.
Thank you very much for that presentation. So my question again is related to those who are vaccinated and then got measles. It's pretty worrying, and I worry that the community may actually lose their confidence in the vaccination program. So that being said, was there anything that was done in terms of public health action to cater for that? Because ultimately they won't bring their children if they are vaccinated and then still get the disease. Over.
Okay, thank you very much. For the first question, as I said before 2022, that is from 2021 downward, in Liberia, there was just a single dose of measles vaccine given at 9 months to render the child fully vaccinated as per our protocol. If any vaccine was received, that was through maybe through a massive vaccine campaign or through the SIA. So, but the protocol says at the time that at the age of 9 months, a child should be able to receive a dose of vaccine, and that child was immunized. But it is now from 2022 down, up to present, we are giving 2 doses now, making them to be immunized. So, for the second question, we all share the same view, like people vaccinated. This is why I placed that in the recommendation, that people vaccinated, why are they still contacting the virus? So a thought of our idea came that maybe the 1 dose at a time was not potent enough. And if you see, I said the outbreak may have been due to low immunization program, because in Maryland, to even leave from the capital Monrovia to go there now, you have to pass by the way of Africa. So there are times we are having breakdown in coaching. The solar fishes at the facilities are down where we'll be doing fast coaching. You're taking the vaccine, maybe store the vaccine at another health facility far away from your district, and then transporting them daily. So it could be some of the problem, but there is a need that we do further study to know whether the vaccine they are giving were potent enough, or whether they were given the right way or so. So these are some of the studies that we are now recommending to conduct to know why it is happening, because we all share the idea that the community might lose confidence in our immunization program if this thing continues. Thank you very much.
Thank you. So thank you all. I think that we've learned a lot from these 3 presentations. There is a need for us to search for the answers why we are getting measles in spite of we having the vaccines. And we've also realized that beyond the associations that we may find, there are some deeper questions we want to know. Are the vaccines potent? Issues related to cold chain? What about the health worker attitudes? What about the community perceptions? These are questions that we all need to ponder over and be able to try and get the solutions or the answers, so that subsequently when we meet here, we may not be discussing only the associations, but we'll go deeper and find the answers to these questions. On this note, I want to thank you all for paying attention, and also thank the presenters for the nice and insightful presentation. We have a plenary session which will be starting immediately from here, so I would like to encourage all of us to be there. Thank you.
Chukchukun tu nyongine.
Cheese. 1, 2. Check. Check.
Check on 2.
Sir, do you have the second microphone? Yeah. Okay.
You see, this one cannot work when you are here because of the signal. The signal is up there. Oh. Not unless the translator, there is no translator there.
There's one.
Because my signal is here.
I'm here.
Not unless you climb there. You go upstairs.
Okay.
I've seen it. I give you the pin. 462530, yes. Has it cut?
Sessions today. It's fine.
Okay, colleagues, can we settle down? So, good afternoon. And I want to welcome us to this very session that is looking at the concurrent oral session 4. And the theme on this is non-communicable diseases, injuries, mental health, and vector-borne and neglected tropical diseases. So we have... Okay, thank you. So in this session, we are going to have a total of four presenters. I just want to call their names and make sure that they are here. So do we have Sahilu Tesfaye? Okay, great. Do we have Frederick Omar? Okay. Please, can you come to the front and occupy this first row? Do we have Mario Avellino? Mario, please, can you come this way? And we also have Maria. Okay, please. You okay there? Okay. Okay, so thank you. So like you all do know, you're going to have your presentation for 10 minutes. Please, let's keep to time. Our evaluators are here, and they're going to take, they're going to be scoring our points. So, and colleagues, let's take down notes so that we can also throw in our questions at the end of it. I'm Dr. Charles Akatobi Michael. I work as a Senior Technical Officer with African Center for Disease Control and Prevention. And I'm actually standing in for Dr. Patrick Nguku. So we'll take our first session, which is Malaria Outbreak Investigation and Report. Wama Cluster of Mana, Sibu, Wareda, Ethiopia. Okay, so let's have Saliu Tesfaye come up.
Shall I start? Okay, good afternoon. My name is Sahilu Tasfahe. I am from Ethiopia, an advanced field epidemiology. So I am going to present the presentation entitled as Malaria Outbreak Investigation and the Report in Wama Cluster of Manasibu Warada, Ethiopia in October 2020. As an introduction, Ethiopia is a high malaria burden country, so Ethiopia has experiencing different outbreaks at different time, including that occurred in Wama cluster of Manasibu. Wama cluster reported upsurge. Wama cluster reported upsurge in malaria cases, especially starting from week 38. Due to cases flowed from Tiuk Abales, Wama Tobara, and Chala Dabus. But in AP week 41, it was declared as the outbreak since it crossed the threshold. So it requires the response. So for this investigation, we set the objective, which is aimed to describe the magnitude of malaria outbreak, identify the etiologic agents, and the factor associated with increased malaria transmission. The study was conducted in Wama cluster of Manasibu from October 5 to 26 in 2020. Figure 2 indicated the study area. The study area is to the western part of the country, located in the western part of the country. For this investigation, we set some case definitions. So suspected case means the patient with fever or had history of fever in the last 48 hours and lived in malaria endemic areas or had history of travel to the malaria endemic areas within the past 13 days. For confirmed cases, any suspected case that was confirmed either by microscope or RDT for malaria parasite. In this investigation, we conducted the descriptive epidemiology as well as the analytical epidemiology. In descriptive epidemiology, we used the cross-sectional study design to describe these suspected cases by place, person, and the time. We selected about 605 suspected cases from the line list. In analytical epidemiology, we used unmatched case control study design. In this case, cases were selected based on the national case definitions, while controls were selected from the community who did not develop the sign and the symptoms. So the ratio of case to control in this study was 1:1. In this analytical epidemiology, we calculated the sample size based on the assumption from previous conducted studies. So finally, we obtained about 117 cases and 117 controls. After we gathered our data, we checked the quality of our data. Then we moved to the analysis. So descriptive analysis was computed and presented by frequency, mean, and proportion. Again, both bivariate and multivariable analysis were conducted. In the multivariable analysis, we tolerated the p-value less than 0.05 at 95 confidence interval. These are some of our findings. Of 605 suspected cases, females were accrued to 60%, sorry, while males were about 40%. The mean age for these suspected cases was about 17 plus or minus 15 years. According to figure 3, the predominant Plasmodium species was Plasmodium falciparum, which is followed by Plasmodium vivax. Table 1 shows that the malaria attack rate by sex and age. So in this case, females were highly attacked by this outbreak. Again, children between 5 to 14 years age, highly affected. The malaria case increased starting from epi week 38, but it crossed the action threshold in epi week 41, and it continued for the outbreak continued for 3 consecutive weeks, as it is presented in Figure 4. Figure 5 indicated that the epi curve. In this figure, the outbreak was reported and the investigation was started on the same date or day, which means on October 7, 2020. Table 3 shows the bi and the multivariable analysis. So in this case, we obtained about 4 associated risk factors. Staying outside overnight, and actually we have got about 4 variables. When we interpret for the first factor, which means staying outside overnight, the odds of contracting malaria among people who were staying outside overnight increased by a factor of 5.09 as compared to those who did not stay outside overnight. As discussion, the maximum cases were reported in between the age 5 to 14 years. This finding was similar with the study conducted in another area of Ethiopia, which is Simada district. Again, females were also highly affected in this outbreak. This might be due to activities or lifestyle related to the females, because females spend their time, most of the time, in unprotected kitchen, especially during the evening. Again, female moved from place to place for searching water from the river or ponds. As a conclusion, the attack rate was high among females as well as children between 5 to 14 years age. The predominant Plasmodium species in this outbreak was Plasmodium falciparum. The outbreak was facilitated by different factors like staying outside overnight, presence of stagnant water, uncovered water storage, and the presence of rivers close to the community. So as a recommendation, we recommended to drain and clean the stagnant water, removing unusable water containers and materials from the residency area, or covering the usable materials. Again, it is better to distribute insecticidal treated bait nets for all households, but if it is not possible for households with highly vulnerable individuals. Again, educating local residents on how to use vector control tools. Finally, we recommended strengthening the surveillance system. Here are some of my references. I would like to thank all these groups. Thank you.
So can we have the second speaker, Frederick Omar. Frederick will be speaking on adherence to malaria treatment guidelines in health facilities in Kenya 2022. Frederick, your time starts now.
Okay, good afternoon. My name is Frederick. I'll present on adherence to malaria treatment guidelines in Kenyan health facilities in 2022. I'm from Kenya Field Epidemiology Laboratory Training Program, advanced level. So malaria, which is a parasitic disease that is transmitted by female Anopheles mosquitoes and caused by Plasmodium species, is was responsible for close to 250 million cases in 2021, and there were approximately 619,000 deaths according to the World Malaria Report of 2022. And Africa bears a disproportionately large proportion of this burden, with about 93% of the cases and the deaths coming from the continent. So the World Health Organization developed a test, treat, and track policy to promote universal access to diagnosis and treatment for malaria. That's slightly over a decade ago. Kenya, which is one of the 15 top high-burden countries in the world, found within the sub-Saharan Africa, reported approximately 4.2 million cases in the same year, that is 2021. According to the national treatment guidelines, all suspected malaria cases should be tested for malaria, and only those that are found to be positive treated with the correct treatment, depending on whether they are uncomplicated or severe cases. Now, there is very scanty recent data concerning adherence to the guidelines at a national level. Most of the surveys that have been done more recently are based on specific regions for particular purposes. So for this purpose, we conducted a national survey in 2022 to assess the adherence to these treatment guidelines in Kenyan health facilities. So this was a cross-sectional survey where we retrospectively reviewed the data from the health facilities. The population included the suspected malaria cases in the health facilities, the health workers working in these particular health facilities, and we collected also some variables on the facility factors in the public and faith-based health facilities, which are supported by the government. A proportionate representative sample that was certified was obtained from the Ministry of Health master facility list. We considered the facility level and ownership, as well as administrative units, that is the counties within the country. And the sample size was calculated to detect a 15% point difference between the current survey and a previous survey that was conducted in 2021. Therefore, we had a total of 94 county hospitals and 79 level 2 and level 3 facilities. Those are dispensaries and health centers. We collected data from the health workers using a structured questionnaire. We also collected data from the patient data, from the patient cards for the outpatient, as well as patient files for the inpatients. And the data we collected included biodata, as well as diagnostic and treatment data. Health facility data also collected using a questionnaire that is based on whether they had certain diagnostic materials, rather diagnostic and treatment commodities, as well as information, education, and communication materials. We analyzed this data by frequencies and measures of central tendencies, and we also conducted a chi-square test to assess the factors that are associated with adherence to the guidelines. So here we can see that we had a total of 173 facilities, of which slightly over half were hospitals. We had about 47 faith-based health facilities, and the rest were public facilities. And as far as the suspected malaria cases are concerned, we had about 60% of them being inpatients. And for the health workers, we had 492 that were interviewed, of whom 60% were in the inpatient sections. Females and nurses contributed slightly higher proportion. So in the outpatient section, as far as the malaria cascade is concerned, we had a total of 1,068 suspected cases, of whom only 62% were tested, or rather there was evidence of them having been tested for malaria in the records. And of these 652 cases that have been tested, about 40% were positive for malaria. That's a test positivity rate of 40%. And 87% of those that were confirmed to be having malaria, that's on the far end, were treated for malaria. That is 87% instead of the expected 100%. For those that were treated, only one patient did not receive the correct treatment. We expect that for outpatient cases, which are uncomplicated malaria cases, they're supposed to be treated with artemether-lumefantrine according to the guidelines. But we had one patient who was treated with quinine tablets, contrary to the national treatment guidelines. So along this cascade, you can see there are few patients that were suspected to have malaria. Although they are not really few, but 1% of the patients that were suspected to have malaria but were not tested ended up receiving treatment. And there's another 2% that tested negative for malaria and still received treatment for malaria, as you can see from here. So that is as far as the outpatient malaria cascade is concerned. In terms of the various endemicity regions within the country, we saw that the high-risk areas, the performance in terms of the ARISTO guidelines was at 63% compared to the low-risk areas, which performed at around 57%. Then as far as the inpatient performance is concerned, so we expect that when a patient is admitted, they are supposed to get a test done for malaria. 86% of the patients were tested for malaria on admission. And then we also expect that after admission, the test would be redone to confirm whether the parasite had been cleared. But we only had about 6% of the patients having the test redone. For those that were confirmed to be positive in the inpatient and they had signs of severe malaria, 94.8% of them were receiving AFENET injection according to the guidelines, meaning that there were some that were still receiving incorrect treatment. And for those that were positive for malaria but did not have any signs for severe malaria, they are supposed to be receiving oral medication, that is artemether-lumefantrine, but the situation is that we were seeing only 6% receiving the correct treatment. So most of them did not have signs of severe malaria, but they were receiving treatment for severe malaria, that is parenteral artesunate. Then when it comes to those that tested negative, but had signs that are similar to those of severe malaria, we had about 23% of them receiving artesunate injection, despite being negative for malaria, meaning that quite a number of patients were still getting treated incorrectly. And those that were negative for malaria and did not have any signs of severe malaria in the wards, but somehow within their files, they had been suspected to have malaria, so they were sampled. We had a situation whereby 13% of them were still receiving parenteral artesunate, contrary to the guidelines. Then on bivariate analysis, we had some of these factors being associated with the treatment guidelines, including public health facilities, availability of information, education, and communication materials, stockouts of MRTs, availability of the treatment for malaria. Then on multivariate logistic regression, the factors that were finally found to be associated with adherence to the guidelines included public health facilities, which were 2.7 times more likely to adhere to the guidelines. Then availability of pediatric doses of artemether-lumefantrine. Facilities that had them were 2.3 times more likely to adhere to the guidelines. The facilities that had malaria posters, that is information, education, and communication materials, were also close to 2 times more likely to adhere to the treatment guidelines, while those that had stockouts or had recorded stockouts of malaria rapid diagnostic test kits were less likely to adhere to the treatment guidelines. So on the conclusion, the adherence to the guidelines was relatively low. The overall performance was 60%. The better adherence to the guidelines was associated with public health facilities, availability of visual aids, as well as availability of malaria commodities. We recommended to the National Malaria Control Program and the counties to strengthen commodity security and strengthen dissemination of malaria IEC materials, as well as capacity build the faith-based facilities so that they can also improve their performance. And after this, we conducted some public health action. We disseminated these findings to all the counties, and we initiated a project called the Malaria Case Management Mentorship Project, in which we trained the county and sub-county health management teams on malaria case management mentorship, and then they were sent ahead to go and conduct mentorship visits in health facilities. They've done 2 rounds of the same so far. These are some of my references, and I'd like to acknowledge these institutions. Thank you.
Thank you very much. Frederick, you overshot by 30 seconds. So we're going to take the next presentation, Evaluation of Malaria Surveillance System in Mozambique, 2017 to 2021. Mario, the floor is yours.
Afternoon. Chamo-me Mário e vou apresentar sobre avaliação do sistema de vigilância em Moçambique 2017-2021.
2017-2021. Malaria is a very high-risk sickness, and in 2016, Mozambique introduced the National Information System that is called SIGMA. Then the system became the main principal national malaria control system in 2018. Through the survey we had of the indicators, we found that the highest prevalence was in the children of less than 5 years. And actually, Mozambique is the 4th country in the world with the highest malaria burden, accounting about 4.1%. And in that period, 12.4 million malaria cases were also reported. Our objective is to be able to evaluate this surveillance system through the system called SIGMA, and specifically to describe the malaria surveillance system through SIGMA 1, 2, to be able to evaluate the qualitative attributes, which are simplicity, flexibility, acceptability, and the quantitative attributes, opportunities, timeliness, and quality of data, and also to be able to analyze the usefulness of the system as a method. We were based on the CDC. The study was carried out in Mozambique. The period was between 2017 and 2021. The population was all malaria data reported within the system, within this framework in this period, and the data collection was done in a semi-structured questionnaire through the SIGMA, and our analysis was done in the Microsoft Excel version 2016. This is the system flow system to say that our system flow starts within the community, where we have the community agents which are responsible for the testing and treating the malaria, no severe, and therefore all data is sent to the health facility where we have our malaria focal point. This also compiles all the information weekly and sends it to the district level, and the district is responsible for the introduction of data into the system, the supervision, and also giving of feedback. And once the data is validated into the system, they are sent to the SIGMA and at the same time to the provincial level, and a central system which is able to have access into the information. And the second table here has been able to also simplify further these attributes. We were able to evaluate, and we were able to ask on the social demographic characteristic of our interviewees. That means that we interviewed this group of professionals, and once they are professionals capable of giving the information that is valuable and on the functionality of the system. And 52.7 was masculine, 47.2 were district focal points of vigilance or supervision, and 63.9 were people who were didn't have more than 5 years of experience. And for our attributes, in terms of simplicity, we also questions the interviewees on the frequency of the use of the SIGMA, the flow of the information, and the necessity of to be able to appropriate the system. And our parameters were how the frequency, always, weekly, and simple. And in terms of the flow of the information, we had this less of the 3, and 3 is level of complex, and to be able to training, to be able to operate the system, less than 24 hours was simple, and more than 24 hours that was considered to be complex. And 91.7% said that they use the SIGMA in a very frequent way. 100% said that they obey 3 levels, which is the district level, provincial level, and the national level. And 100% said that to be able to use the system, they needed at least 24 hours of training, and so we considered our system more simple. In terms of the flexibility, we can say we questioned the interviewees on this new variation, and also to be able to the ability and also the continuity in turning the data into the system. And we had yes, flexible, no is not flexible. 86.1 of the interviewed said that it is functional with the introduction of the new variable of the fever in 2020. And 88.9% said no, even with the change of the personnel, the SIGMA was still functional, because at every point of contact of data, with their personnel that are trained. And for us, we felt that this was flexible. And in terms of the attributes, on the acceptability, in terms of the experience using the system, if you had an opportunity to change for another, would you do so? And our parameters were low, that is less than 70, moderate 70 to 89, and high, that is more than 90. You can find out that 88.9 said that no, and this other side said 11.1, so we consider the system moderate given the facts. And in terms of the evaluation on the timeliness, we would say that timeliness refers to the ability of the system to be able to send the data in the established timelines within the deadlines. This was determined within the ratio between the number of reports that were sent on time and the number of reports that can be received also in time. So the parameters were less than 80% and timely for more than 80%. And if you can check on the graph there in 2017, you see that we were at 80.1. That is the year that SIGMA was firstly used, and they had 6 months of use. And we can see this as a growth. So we can say that in Mozambique, that one part, that is the northern region, the Cabo Delgado, was affected by the armed conflict. So that could have been one of the reasons that led to these changes in the data. And so our system was considered as timely. And in terms of the evaluation of the data, in terms of the completeness of the reports, that all the reports are sent to the system and are also compiled. For that, we were able to calculate the ratio and the total number of we could say the parameters were lower, below 70%, moderate 70 to 89%, and high, that is more than 90%. And according to the data, we could see that we look 2017, that was 6 months after the introduction of the SIGMA. We can see that the number is quite high, and 2019 is highest. 2020 was lowered a bit, 2021, and that is because of the problem of the COVID-19 and also because of the armed conflict that we were experiencing in the province of Cabo Delgado. And in terms of the criteria of our evaluation, we were able to classify the data as high data completeness. In terms of the utility of our system, to say that the system was able to prove to be useful because it monitors all the cases of malaria throughout the year and also allows the public health authorities can be able to define clear strategies to be able to control and eliminate the disease. And all the interviewees were able to affirm that the easiness of the operation of SIGMA, which is flexible to the changes, and the structure is the system is well structured and very easy to manage. The study was carried out in Benue State in Nigeria, and also in timeliness of our reports. This is a very crucial cog for the timely decision making, because if you send late reports, it is hard to make clear decision and timely. So the delayed and insufficient reporting for the surveillance system can hinder the assessment of disease and the detection of outbreaks. And we had some limitation, for example, the violation of the current database, and some students were saying he didn't have access to the system, and also the qualitative attributes were accessed through interviews. That means that the study can also have more angles on the conclusions. And we can also say in conclusion that the vigilance of malaria in Mozambique was simple due to the user-friendly surveillance tools, which was also flexible, because it allowed the introduction of a new variable, fever, without requiring additional costs and extra costs. And also we can say there was high acceptability among stakeholders, there was high timeliness and data completeness, and the system also showed that it was useful and functional. So we recommended to the National Malaria Program to do or carry out regular analysis every 2 weeks for the able to have early detection of malaria, and to be able to make clear decisions to avoid malaria, and also periodic evaluation for the malaria on the surveillance system, which is key to be able to continue bettering our system of vigilance. So this is our reference. Thank you.
Thank you, Mario. You used 11 minutes. And so we'll have the last presentation, but not the least, and it will be taken by Maria. Maria will be presenting on malaria outbreak investigation in Katima, Mulilo District, Zambezi Region. Mare.
Good afternoon, everyone. I'm Anette Likando from Namibia, presenting on behalf of Maria Angala. I'm going to present the malaria outbreak investigation in Katima Mlilo District, Zambezi Region, Namibia, 14 to 25 March 2022. This is going to be the outline of my presentation. Malaria is a vector-borne disease caused by Plasmodium parasites, transmitted through the bite of female Anopheles mosquitoes. Nearly half of the global population is exposed to malaria, according to WHO. In the year 2021, 247 million malaria cases were reported in 84 malaria endemic countries, which showed an increase from the previous year. Africa accounts for about 95% of all these cases. Namibia is endemic for malaria in 9 of the 14 regions. Approximately over 1.6 million population are at risk of contracting malaria in Namibia. Zambezi region is the highest burden malaria region in the country. This has been going on over the years, with all year through transmission. During Epi Week 2 of 2022, a sharp increase in malaria cases was noted by the Katima Mlilo district. And then they declared the outbreak in Epi Week 5 of the same year. And then the Katima Mlilo district decided to ask for assistance from the epidemiology division, which then responded by sending 2 FLTP residents and alumni to formulate a team that will investigate and describe the cases into person, place, and time, and then identify the possible drivers of transmission. These are just some of the field pictures showing where picture 1 is showing where we were sitting with the management of the hospital, Katima Mlilo District Hospital, briefing them on the investigation. And then picture 2 is showing the investigation team sitting around the table to formulate the data collection tool. The study was conducted in Katima Mlilo District, which is the only district in Zambezi region. It's a one region, one district. Estimated population of over 109,000. It's a tropical region known for high transmission, and it's also known for high temperatures, high rainfall. It's also prone to floods. A lot of farming and fishing activities are known for this region. So the picture there, or the figure 1, is just showing a map of Africa, which is zooming into Namibia. And then in Namibia, it zooms into the Zambezi region, where the study was conducted. We conducted a descriptive cross-sectional study where we reviewed malaria surveillance data from Epi Week 1, but the investigation was conducted in Epi Week 12 and 11. We also traced cases and interviewed them at a household level using interviewer-administered questionnaires. We interviewed guardians for the underage children and then conducted environmental assessment around the houses that we visited. We defined the case as any person positive for malaria by either microscopy or RDT between the 1st of March and 25th of March 2022. We then analyzed this data into frequencies and percentages using Microsoft Excel. A total of 38 malaria confirmed cases were then followed up. This is a demographic information of the respondents. So from the analysis, most of the respondents were male, making up 58%. And then the age group of 10 to 19 reported most of the cases with a 32%. The level of education of the respondents, it showed that most of the respondents' highest level of education was primary school. Malaria cases distributed by health facility. So the highest reporting health facility was Sisheke, followed by Sibinda. So when we got in the field, we went backwards in time. Even though it was week 11 and 12, we also went back up to week 1 just to see how the cases had been reported throughout the time. And this is the EPICAV that we came up with. And you can see that on the EPICAV, the investigation continued even after we left the field, so the cases were being still under surveillance. So you can see there that the outbreak investigation started in week 11 and ended in week 12. Majority of the cases or respondents indicated that they slept in unsprayed structures or unsprayed houses, of which 17 of them said the spray teams did not reach their area during the last spray season. A lot of them, 32, did not have any treated mosquito nets. Over half, 21 of them indicated that they were engaged in outdoor activities in the evenings for long hours. And all of the respondents had the presence of vegetation nearby. This was a result that we found from observing. More than half respondents indicated that they have not been educated on malaria prevention. The limitations of the study: not all the cases could be traced during the 2 weeks of investigation, and the responses were subjective because we only depended on what the respondents were answering. For example, when they say that they don't have a net, or when they say that they have a net, we didn't ask them to see if it was true or not. So we couldn't conclude on our results, generalize the results. So the malaria outbreak in Zambezi region was reported mostly among the males. This could be because they are the ones who are mostly involved in fishing and agriculture activity in the region. Could be due to them also engaging more in social activities. The age group of 10 to 19 years reported most of the cases, consistent with other studies that also found that most cases were below 10 years. This is inconsistent with what we found comparing the study. Most cases, 17 of them, respondents, highest level of education was primary school, as mentioned in our results. So these studies are some studies that we checked and compared showed that a low level of education was associated with the prevalence of malaria infection. The malaria transmission in Katima Mlilo district could be due to the malaria spray teams not reaching all the houses. This could be due to limited resources. And also residents not having treated bed nets also could be attributed to less resources or limited resources. And also the residents engaging in outdoor activities at night and not being educated on malaria prevention. We therefore recommended for the district to ensure universal coverage of malaria spraying. According to WHO, universal coverage should be at least 85%. There is a need for Katima Mlilo district to conduct regular community health education sessions on malaria prevention. We then provided health education on malaria prevention to the houses that we visited, as depicted in the picture there. And then we oriented the 3 healthcare workers that we found there in the villages that we visited. These are some of the references. I acknowledge the following. Thank you.
So I want to really thank the presenters. I think they did a good job in terms of time management relatively. And we've heard the presentation, very interesting findings. I'm a little bit surprised. In Ethiopia, females were more likely to get malaria, but in Zambezi, it looks like the male. So I think those are interesting dynamics, and maybe we should be able to discuss them. So I'll take quickly 3 questions. The first 3 people, 1. Now there's an outbreak of hands. So I'm going to do a bland one, but 1, 2 females, 2, 3. So I'll take 4, please. So let's take the first. Wait. What time do you have? While you're finding out, can we give it to the first person to ask the question? Then you clarify for me what time we need to round up. So please, you take notes. Yeah.
I have a question for Sahilu of Ethiopia. It wasn't very clear what your usual malaria numbers are. we didn't see an epic curve. So what are your usual malaria numbers for us to be able to have declared an outbreak? And it also wasn't clear what caused the outbreak. Were there floods? Because at some point there was stagnant water, but also there's women going to the river, so they get exposed to, they're more likely to get malaria because of the activities they're doing, like fetching water. Was there increased rainfall? Was there an influx of persons? What behavior changes caused the outbreak? And then for Frederick from Kenya, we know that in Kenya, about 38% of facilities are private. Your study focused mainly on public facilities. What proportion of Kenyans are treated for malaria in the private sector? Also, in your public health action, there was nothing that was mentioned about any activities that were undertaken in private health facility. Why so? Why was there no action for such a big proportion of health facilities? And then finally, just a short one for Aneti from Namibia. What economic activities are in Katima Mulilo district? Because males are the ones who are mostly affected, and also the age group that is mostly affected is 10 to 19 years. Are they involved in economic activities that are exposing them to the risk of getting malaria, or why that difference between Namibia and Ethiopia? Thank you.
Okay, thank you. Please, subsequent questionnaires, can we restrict to one question each, please, as much as possible? And let's go straight to the point, yeah.
Okay, thank you. I'm Priscilla Malibo from Botswana. My question is directed to the speaker number 1. You were saying the most affected group was the age 5 to 14. I wanted to know if there are any targeted interventions available for this age group. Thank you.
Thank you so much.
Sorry, please, anyone who doesn't have a lunch coupon can raise your hand so that you'll be attended to. Thank you.
Thank you so much. My name is Thomas Dugan from South Sudan. My question will be directly to the last presenter. We would love to know, how did you define the malaria outbreak in terms of thresholds, which epidemic threshold, maybe alert threshold you use? I'm not seeing that. Thank you.
Thank you. The last person, there were, yeah, one male here.
Boa tarde a todos. Eu felicito todos os apresentadores.
Known
E eu
to
sou
all,
Mamadou
my
Camara.
name is Mamadou Camara, the FTP from Guinea-Bissau. My question is going to Mr. Frederick. Mr. Frederick he spoke about the guidelines and how to the Kenyan Health Minister, they administrate malaria system. I don't know, but we know we have different programs to control malaria in Guinea-Bissau, and I think it's been very hard because we have cases that some cases are positive, and the suspect has all the symptoms, and the resistance from the professionals as to follow the guidelines of the program. And for us, it's a challenging, and this question is going for Frederick. This guy from Guinea-Bissau.
Most prone in Ethiopia to malaria, especially you made allusions to the fact that they fetch water. So given to the biting pattern of their northwest, what time do they fetch the water? Are they mostly evening? And why do you think that that's one of the contributing factors? So let's take the questions as they come. Thank you.
Okay, thank you. I think the first question is about the malaria number. That means we used the 2019 to compare, to declare the outbreak by doubling the 2019 with 2020 data. So after it crossed the threshold, we declared as the outbreak. If I got your question, I don't know. But the other one is regarding the females, why females highly affected and relating with the moving or traveling to the river. So in our finding as associated factor, presence of stagnant water as well as presence of stagnant water is considered as a associated risk factor. So females in rural area, especially in that area, Wama cluster, they moved long distance to searching for water, especially during evening time. So in that area, there is a large river, which is called River Dabus, which is considered as the source of outbreak for this outbreak. Around that area, there is a swamp and stagnant water around that river. The other one is why children between 5 and 40, in finding children between 5 and 14 years highly affected. What was the intervention done for these groups? So as a public health action, we initiated the distribution of bait nets, as well as implementation of indoor residual spray, as well as we worked on the community regarding this. Because in 2020, there was a COVID-19 pandemic and the LZ system somewhat shifted to the COVID-19. The malaria and other cases were forgotten. So we initiated the community regarding the other, including the malaria, especially on this outbreak. So we did like that. Is there any?
Yeah, thank you. I'll start with, is it Tabitha? There's a question that you asked on the proportion of patients that are treated for malaria in the public and the private sector. Now, according to the Kenya Malaria Indicator Survey, which was conducted in 2020, the findings were that approximately 40% of Kenyans received treatment for malaria in the private sector. So that is a significant proportion, yes. And this particular survey that we did, the funding that we received from Global Fund and USAID was specifically focused on the public sector, so to speak. And the government generally supports the public and faith-based health facilities with the malaria commodities and capacity building. But private sectors have generally not been involved in this. However, there has been a private sector quality of care survey that has been done annually in the past few years. And because it's outside the scope of this, we didn't really present it. But the findings were also interesting. Mostly it was showing that the healthcare workers that are capacity built on malaria diagnosis and those that have recently attended a malaria-focused training, particularly on malaria case management, are more likely to adhere to the guidelines. So that is as far as the private sector is concerned. But we omitted it because it was outside this particular survey. There's another question on any action that was taken as far as the private health facilities are concerned, now that they're managing many patients. Yes, there's been some actions that have been done on this, and one of the most recent surveys that was actually last month, the Malaria Journal published some survey that we conducted in the malaria endemic Western Kenya region. And the findings were also similar to the national survey that indicated that the healthcare workers that have been capacity built on malaria case management, particularly on use of malaria rapid diagnostic tests, are more likely to adhere to the national malaria treatment guidelines, as well as private health facilities and drug outlets that have malaria commodities, specifically the malaria diagnostic kits and artemether-lumefantrine, were also found to be more likely to adhere to the guidelines. So as far as public health action is concerned, based on that, the findings of those survey, we've also initiated a separate activity, a project that is called Private Sector Engagement in Malaria Case Management. Currently, it's being supported by the Global Fund, and it's the funding that we have currently is just in 10 counties in the endemic Western Kenya and 2 counties in coast. Mombasa being one of them. So this particular county is also included in that project. We are capacity building the healthcare providers in the private sector to also manage malaria according to the guidelines. and we conduct routine mentorship visits to confirm what they're doing. So that is an ongoing project, but it was outside this particular presentation. That's why it wasn't really included there. The second question was on resistance of the healthcare workers when it comes to adhering to the guidelines. Yes, we have experienced something similar. We have similar challenges, basically. Some healthcare workers, particularly, are not very eager to adhere to these guidelines. However, we have changed our approach to how we handle those situations. This particular project that I mentioned in our public health action involves mentorship rather than what we used to do before. We were basically conducting trainings in halls. So we'd call people to a certain hotel and train healthcare workers there. Then after that, we'd do supportive supervision. But what we are doing currently, we are calling it mentorship. We have trained many mentors at the subnational level, county level, and sub-county level, which is very close to the health facilities. And from this capacity building, they have been trained as mentors. Therefore, we support them routinely every quarter to visit all the health facilities within their jurisdiction and mentor the facility workers on malaria case management. So with this, we've also improved access to the malaria treatment guidelines, which is now available in digital format, and it's been shared basically with all healthcare workers. And we have also started a project through which we are trying to include the malaria treatment guidelines, incorporate it in the preclinical training areas. So as the college and the university students are being trained, we also incorporate the updated versions of the malaria treatment guidelines in their curriculum so that they know exactly what to do before they go out to start managing patients out there. I hope that is satisfactory. Thank you.
Okay, thank you for the questions. Question one was on the economic activities that are in this region. So as I mentioned before in the presentation, that it's mostly fishing and also farming, but also it's a border town, so it has a lot of informal businesses like people selling on the streets up to the late hours, and they also have shabins and all those businesses. Well, the age group of 10 to 19 reported most of the cases, yes, but they wouldn't be so much involved in these economic activities because this is the age group that is going to school. But because most of the cases were reported in the villages or informal settlements where people don't really have living rooms or sitting rooms where they are sitting in the evenings. So this age group would be mostly playing outside in the evenings. Thank you. And then to describe the threshold that I showed on the EPICAV, the threshold that I showed was an action threshold, which since I mentioned that it was all year through transmission for Zambezi region. So this is the threshold where now they went beyond the expected cases using the past 7 years as proxy. Thank you.
I think so. This brings us to the end of the session. Just to say that as they portrayed in the background, malaria still kills quite a number of children and women, pregnant women for that matter. So I think it's something that we need to collectively keep working on to see how we can control its prevalence and the impact it's having. I was recently in China and I was so surprised that with a population as in billions, they've been able to eradicate malaria. And they once suffered outbreaks like we're having currently. So FEL tips and everyone in this room, let's put hand on deck and work with our various communities to see how we can stop this impacts from malaria. Thank you very much for listening and have a great day. Bye. So I think after this, if you've not got your coupon, please call our attention, we'll get you your coupon. Other than that, I think we can break for lunch. Thank you for your attention.
and I hope you're well energized. It's not so easy to talk to people science after lunch. I hope many of you did not eat ugali. You know what ugali is? The white one. It makes people sleep seriously. So I hope you did not eat that. And if you did, please take a lot of water, and then it will all be okay, okay? So that we stay awake to be able to listen to these exciting talks from the work that has been done from different parts of Africa. Yeah, so do we have the first speaker, who is testifying? Prevalence of hepatitis B virus and its predictors among volunteer blood donors in Ethiopia. Do we have the speaker? I think that is the one that we don't seem to get. So if Tesfa is not around, then we can go to the second speaker, who is Coco. How do I pronounce that? Is that the way to do? Coco? Yeah, thanks for that. So we wish to welcome you so that you give your talk. You have 10 minutes. After that, we'll have question and answer session. You're welcome.
Bonjour à tous. Je suis Koku Ayamikbe, FTP intermédiaire Togo.
The FTP intermediary in Togo. I'm happy to present to you a summary of our work of the epidemiological profile of hepatitis B, Lome 221 to 22. This is the plan. As an introduction, we are arguing that hepatitis B, they are infectious diseases that vary from high to chronic levels, and it is sexually transmitted through sexual interaction. In 2015, we had high numbers of people that suffered from hepatitis B, and this would therefore, the figure that you can see shows that the data indicate that between 2020 and 2022, respectively, for hepatitis B and hepatitis C, the data is up to 350 million people who are having hepatitis B. Then in Togo, there has been a collaboration studies that has been done on the prevalence of hepatitis B and C up to 36%. And we had a strategy for the fight against hepatitis through early detection of cases and prevention of transmission. In that framework, we have a center for blood studies that works on supplying data on tested cases, and that is the context in which we carried out this study with the intention to do the hepatitis profile of through the Lome Center. And we wanted to determine the prevalence of hepatitis B and define or describe the socio-demographic profiles of hepatitis B. So how did we proceed? Our study happened in Togo, a country in the sub-region of West African region with about 8 million inhabitants. The region of Lome was selected as the center of the study, and the National Center for Blood Transfusion was also supporting this. This region of Togo had 2,224,000 in 2024. This is the greatest town, carrying all the groups of the young people exposed to hepatitis B and sex workers. It was a descriptive cross-sectional study from 1st December 2022 to 22nd January in 2023. We went to get data from the primary source of the National Blood Transfusion Center, and this is where we analyzed this data. We had features such as the gender and matrimonial status and so on. So we now go to the results that we obtained during the study period. We interrogated we had 367 for hepatitis C, corresponding to 1.8% of the cases. We observed as well that 2021 was the year when the prevalence was high, 3.7% of the cases. Figure 3 represents the spread of the carriers of hepatitis B. 2021, 2022, hepatitis C dominated. In this figure, we see the spread of hepatitis on gender and age for in Table 1, we are now presenting the prevalence of hepatitis across professionals. We note that the most affected group is teachers, office workers, and security workers, respectively, with 7.1%, 6.3%, and 5.5%. In this table, we are presenting prevalence by municipalities. Gulf 1 was highly represented with the highest number of cases, followed by the Agoe, which is 5 and 6 for the Agoewe municipality. We have discussed a number of our results. Our prevalence of hepatitis B was 2.3% of our results, and this prevalence is high and can be explained by the fact that in Morocco, the vaccine against hepatitis was introduced in 1998. In Togo, it was in 2008. We note that we need more sensitization so that prevention measures can be put in place by the populations. The prevalence of hepatitis C was higher than that of B, and the results, other results in Ghana and elsewhere gave contrary results. In Togo, in the general population, the prevalence of hepatitis B was higher than that of C. The study was representing only 10% of the data collected, and this trend could change if we take the entirety of the donors. Given that we don't have vaccines for hepatitis C, those vaccinated against hepatitis B believe that they have been vaccinated against C, and that explains the high trend. For men, those who are unmarried were highly represented, and this can be explained by the fact that the main donors were more active sexually and they would be neglecting preventive measures. What do we take? The young people were more affected across the two genders for the two forms of the viruses. We need to do a further study on capturing the various behavioral patterns around the two viruses. We need to do a more targeted communication for the two groups, as we may recommend. These are some of the references that we want to cite and recommend. Thank you very much for your listening, and thank you to those who supported us.
For keeping the time. What I suggest is that we have the second presenter. Please note down your questions for Coco. Then we have the second presenter, And then after the two present, then we'll have a set of questions for both of them. So now allow me to call upon Sifiso so that you can give your presentation. You have 10 minutes, Sifiso. It's good to have some fans in the room, so for motivation.
It's not here. Okay, afternoon, colleagues. Standing in front of you, it's Mr. Sithole from South Africa, FETP. I will be taking you through the prevalence of hepatitis B virus in Mpumalanga province, South Africa, from January 2020 to September 2022. So this will be my presentation outline. These are the abbreviations that will be used across the presentations. So in brief, hepatitis B is the inflammation of the liver, which is transmitted from an infected person to an uninfected person. It can be sexual, can be through sexual contact, sharing of needles and syringes, and through vertical transmission during pregnancy and labor. Hepatitis B is a vaccine-preventable disease which can progress and complicate into liver cirrhosis, liver cancer, and even death. It is prevented by hepatitis B vaccine, which is readily available for both adults and children. So in South Africa, hepatitis B is a notifiable medical condition which must be reported to the public health authorities within 7 days. Globally, over 296 people had hepatitis B, with an estimated new infection of 1.5 million people and over 820 deaths, mostly from liver cirrhosis and liver cancer. So in South Africa, over 1.9 million people were chronically infected with hepatitis B, with an estimated prevalence of 6.7 of the population in 2019. Therefore, in Mpumalanga province, a total of 279 hepatitis B cases were reported. The study was conducted to estimate the prevalence of hepatitis B and to assess the quality of hepatitis B surveillance data in Mpumalanga province between January 2020 and September 2022. So we plan to conduct data quality assessment of the hepatitis B surveillance data to describe the epidemiological characteristics, to determine the prevalence of hepatitis B in the province, as well as to recommend preventative measures and plans to improve data quality. A descriptive study design was conducted in Mpumalanga province. Mpumalanga is a province that is situated in the eastern part of South Africa with an estimated population of over 4 million, bordering the nations of Mozambique and Swaziland. It has 3 districts, namely Ehlanzeni, Hersibande, and Nkangala districts. It has 28 hospitals and 287 clinics. Only laboratory cases were included in this study, which were defined as any person with an onset clinical symptoms of fever, headache, anorexia, nausea, vomiting, diarrhea, abdominal pains, and jaundice, and a positive immunoglobulin M hepatitis B core antibody and a hepatitis B surface antigen. Secondary data was used from the notifiable medical condition surveillance system, which is being fed, which feeds from the paper-based notification forms, which are being completed upon diagnosis by healthcare providers from health establishments and forwarded to the relevant public health authorities. This process must be completed within 7 days. With regards to data management and analysis, Microsoft Excel 2016 was used to clean, sort, and categorize data. Then subsequently, descriptive analysis was conducted. Data was presented in tables, graphs, and charts. With regards to data quality, proportions were used to assess missing information, and variables were assessed for data completeness, targeting over 80% or 80% and above of completed data. Therefore, the province prevalence was calculated using the mid-year population estimate. After data analysis, we established that only 2 variables had over 80% of data completeness, while the rest of the variables had less than 20% of data completeness. More males were affected by hepatitis B aged between 20 to 49 years of age. Then for the 3-year period, we established that majority of hepatitis B were reported in 2020 across all the 3 districts. The prevalence rate of hepatitis B in the province was decreasing from 2020 to 2022, and for the duration of the study, we discovered that the prevalence rate was 6 people per 100,000 population. So in discussion in our study, we have established that poor data quality was evidenced by a high proportion of missing information, and studies suggest that the way data is being collected and recorded has an impact, as well as the simplicity, acceptability, and stability of the surveillance system. People aged between 20 to 49 years were mostly affected by hepatitis B, and again, the study suggests that risky lifestyle habits among these individuals might be the cause, and which can include multiple sexual partners, unprotected sex, sharing of needles and syringes. Distribution of hepatitis B cases in both genders were comparable, although studies that were conducted in Greece, New Zealand, and Taiwan suggested that males progress faster than females to chronic hepatitis B. We could not explore variables for occupation and comorbidities since there was no data in our data set. These variables could have assisted us to identify people that are at high risk for contracting hepatitis B, which are healthcare workers, people that are living with HIV, people who inject drugs, and people who are working in sewage plants. And as well as to identify if there's any co-infection of other conditions such as HIV and AIDS. So in conclusion, our study we have established that there's poor data quality was observed, and majority of hepatitis B cases were reported in 2020. This is during the peak of the COVID-19 pandemic, where COVID-19 restrictions were implemented. So we recommended evaluation of the hepatitis B surveillance system in the province to identify gaps and develop action plans, as well as to raise awareness on hepatitis B and encourage healthy lifestyle practices through radio slots, social media platforms, community engagements targeting people aged between 20 to 49 years of age. So in celebration of the World Hepatitis Day under the theme One Life, One Liver in 2023, we have conducted an awareness campaign on hepatitis B, where we're educating communities on hepatitis B. We also collaborated with other stakeholders who assisted us in distribution of IEC materials to various communities, as well as we also conducted training for healthcare workers on hepatitis B and the notification process. These are my acknowledgements, references, and thank you.
So thank you very much, Sifiso, for that presentation, and good to note that other than doing your research, you identified the problem and you actually tried to do some interventions during the Hepatitis Day. So those are the first 2 presentations that are on hepatitis, and now I call upon the people who could have questions for each or any of the 2 presenters to please ask now. Yeah, there's a question there.
All right. Thank you very much to the two presenters. I think it was really very, very insightful, and we learned a lot from them. My first question is going to Kuku, if I got his name very well. Kuku, you did a study looking at the prevalence and the socio-demographic characteristics of hepatitis B. And you said you did a descriptive cross-sectional study. But I learned that your study period was 2020 to 2022. So I was asking myself, how could this have been a cross-sectional study? Probably you can elaborate on that. And you also said, the prevalence from the study, the highest prevalence was among teachers, but I didn't see in your discussion what could have been the reason for the high prevalence among teachers. And what was your likely public health action you did to solve anything? To Sifiso, okay, sorry if I didn't get it right. I think that was a very good one. In your conclusion, you said the data quality was poor, which was one of your objectives because you wanted to look at the data quality of hepatitis B data. But the first objective of your study was to look at the prevalence of hepatitis B, and you never concluded on that. I wanted to know whether the prevalence was high or it was low. Thank you.
Thank you, Coco and Lucky. Fantastic presentations, insightful. I just have, Lucky, help me clarify something. Your public health action, you train health workers on reporting. Well, I don't recall seeing anything in your results, in your findings, that informed that decision to train health workers on reporting. Could you please just clarify? Thank you.
I think we can have them answer those ones first. Coco, go first. Go first.
Merci beaucoup, modératrice. Merci aux collègues.
As well to the colleagues who asked questions, and that is evident that you had a lot of interest in our study. The first question was to confirm really it was a cross-sectional study because we collected data across 2020 to 2022. I can say it was a cross-sectional study because we described the characteristics of the carriers of hepatitis B from 2020 to 2022. And given that it's a description of the social demographics, we can only undertake a descriptive cross-sectional study. The study is still on, and so we presented the descriptive part. We will go into another analytical phase to determine the factors that can explain the prevalence of hepatitis B among the group of teachers. The challenge we had is that for the National Blood Transfusion Center, when you, over time, we have certain parameters that have evolved to the extent that when the prescriber discovers that you have a certain number of factors, you are eliminated. And because it was, we were able to extract the data, and we were not able to capture the behavioral aspects in order to explain the prevalence of hepatitis B among teachers. So we will do another protocol to do a prescriptive study during which we will be able to interrogate the teachers and the groups that are highly represented to enable us capture the behavioral aspects that would explain these predominance in terms of prevalence rates among teachers. Public health actions, we made a recommendation to the heads of health centers and the National Blood Diffusion Center and heads of institutions to sensitize people on issues of prevention so that they don't really consider vaccination against hepatitis B as a foolproof protection against infection. Thank you very much for the keenness that you demonstrated during the presentation.
Okay, thank you so the first question was asking why did I not conclude on the prevalence. You wanted to know whether it was high or low. So the prevalence that when we calculated, we've realized that the prevalence was decreasing from 2020 to 2022. 2020 it was 3.7, then 2021, 2022 it was only one person per 100,000 people. Therefore, with regards to the second question, what informed me to train workers on reporting hepatitis B, as it was mentioned on my public health actions. So if you remember at the start of my presentation, I mentioned that hepatitis B is a notifiable medical condition which must be reported by healthcare providers within 7 days. So when we're reporting notifiable medical condition, which is hepatitis B, we are filling in a notification form whereby you're filling in the demographics, the signs and symptoms, traveling history, coexisting diseases and all those things. So we decided to train healthcare workers on notification process to further explain and give them education on how to fill that form, because when we're analyzing our data, we have discovered that so many variables had no information. So by giving them an health education or training on filling in the notification form will maybe improve our data quality as well. Thank you.
So thank you, Sifi. So do we have any other question?
Thank you. It's Kuriso from South Africa. My question goes to our first presenter. So in terms of the prevalence of hepatitis that you presented, for 2020, 2021, the prevalence was more or less the same. But in 2022, we saw a drop in the prevalence. So I just wanted to understand what could be some of the reasons, for such drastic drop that we saw, whereas for 2020, 2021, it was, more or less the same, but 2021, there was a drop. Could there be any reasons for that particular drop? Thank you.
Thank you. I think my question is actually a follow-up to what he just highlighted. For your reporting period, for 2020, it was January to December. 2021, January to December. 2022, correct me if I'm wrong, I think ended in September. So kindly clarify how you calculated this to be sure you didn't, because you're not comparing equal periods. So how did you address this?
So we can address those two questions, then we close the hepatitis discussion. Coco, go first, please.
Merci beaucoup. La baisse de la prévalence.
The drop in prevalence in hepatitis in 2022. In 2022, that is the thing. Actually, in 2022, the prevalence rate was higher. It did not drop in 2022. Actually, the prevalence of hepatitis C was higher than that of hepatitis B, but we did not have any drop in 2022. 2022? Thank you.
Okay, thank you so much for that question. We acknowledge that in our study 2020-2021, we calculated the prevalence for 12 months. Then 2022, it was only for 9 months. That is when the study was conducted. Hence, we only used the mid-year population estimate for the year, not the general population, the general estimate for the country that was released in July. So that is why we couldn't use the general population as a whole. So we only used the mid-year population estimate to calculate, since 2022 was only 9 months, not 12.
So thank you very much. Join me in applauding the two young investigators. Thank you so much. And now let's move. Can we stand up and dance? Okay. That is from South Africa? Okay. Thank you for that. Tomorrow, when we have the international night, we hope you can be able to show us more of that. So let's now move on to MPOX and listen to a presentation by Hastings Chinedu on risk perception of MPOX. I love the spirit in this room. So Chinendo, take the floor. You have 10 minutes.
Is it okay? Okay. How do I shift this? Okay.
This is what is actually shown.
Okay. Okay. But immediately I turn this to show. Okay. Good afternoon, everyone. My name is Hastings. I am an M30 graduate from Nigeria. Okay. So I'll be presenting this afternoon on the risk perception of MPOX transmission among men who have sex with men in Rivers State, Nigeria. So there has been a global change in the dynamics of MPOX, which has resulted in cases among men that have sex with men. And if you look at previous studies that have been done about this, you will even notice that about 85% of the cases of MPOX were usually recognized among men that have sex with men. And in Nigeria, it is conservatively estimated that about less than 1% of the population are in this group. And the populated estimate for men that have sex with men in Rivers State, which is one of the states, just like you have your county, in Nigeria is about 56,000. Now, to know a little bit about the study area, which is Rivers State, where I did my work, Rivers State has a Ministry of Health. It has also its own Public Health Emergency Center for Disease Detection and Response. And cumulatively, this Rivers State has the highest prevalence, of the second highest prevalence in Nigeria among the states. It's a very big state that is known for oil production, and there are a lot of expertise and a lot of cosmopolitan activities in this area. So we have also recorded and documented cases of MPOX in our primary health care center of people that report with genital symptoms of MPOX that were recorded among the primary health care center. So this was one of the reasons that we had to go back and ask ourselves if people have MPOX and men that have sex with men, is there anything that is happening in our society that we need to know? So it's also important to put a disclaimer here that MSM is officially banned in Nigeria, and there are also jail that's attached to it. So the method we use, so one of the objectives to achieve this the objective of this study was to determine the social demographic characteristics of this group key populations and to assess the risk perception of MPOX, since this is the disease that we are noticing about this key population. And the method we used to achieve some of these objectives, we did a cross-sectional study where we developed a questionnaire, an online questionnaire, and we did a purposive sampling through snowballing, and we were able to look at the variables on the social demographics. We also looked at the risk perception. We had a 3-point scale rating that we used to utilize the responses about the risk perception, and we also made sure that we obtained consent from all the members. So in order to basics of field epidemiology, we tried to look at the time, place, and person. we will look at the age characteristics. So what I want you to know in this graph is to know that the average age was about 30, but the number of 25 to 44 years were the highest number of people that we had in this key population. But I also want you important to note that we had a population that were below 14 years, and that was worrisome for us. When we looked at their identities, yes, all of them were men, but we had about 95% that identified of men, and we have a few percent that identified as female, even though they were men. That is to point out that there were heterosexuality identities among this key population. So we look at their relationship status, and we know that about 35% proportion of this group were single. We had about almost the same that were dating, and we also had those that were married in this population. So the map I showed you, the intensified places are the centers of the most urbanized areas in this state. That is the Port Harcourt city, and we also had some cities that are surrounding it. These are the major urbanized cities. So it will help us to look at that most of these activities were in the urban regions. So we also wanted to know a little bit about this group, and we asked them the proportion of respondents about their HIV status. So what I want you to get from this slide is that we had still so many of them who did not know their HIV status, and this was important for us. Also, we also asked them about their, the use of contraceptives among them. Yes, most of them answered that they use contraceptives, but we also, the recreational drug use. So we asked them about the recreational drug use for this population, and we noticed that some of them said they were not using drugs, but we had those that were using it daily, we had those that were using it monthly, and we had those that were using it weekly. So on the contraception, use of condoms among this group, yes, most of them answered that they often use condom, but it was also important for us to note that we had a population that said they've never used contraceptives among this group. And we had those that said they used it every time, and those that said they used it rarely. So one of the objectives was to assess the risk perception of this group. And the risk perception, when we asked them how serious would they dare to get monkeypox, most of them took it very serious, but the majority population of them took it that they were not serious about it, or they were just serious about it. For some of them, it was not an important event. And we know that from other climes and other societies, mpox is a serious concern. And when you look at this population answering that it was not a serious, so we went ahead to say, how likely do they think that they might get this disease? So the greater population of people looked at it that it was just serious, or they were not likely to get some of this disease. So when we look at the risk perception, we were able to find out the average rating for this expression was 1.7, which was very low. The average rating was very low. Those that looked at it, that if it was a high perception, was about 7%, and those that were neutral about the risk perception of mpox were about 46%. So the sources of information, why this is important for us is that we wanted to target, how we will target intervention for this group. And we found out that the hospitals were not providing the right information for them. The only information where they were easily used to capture this was either that they go from the social media, the TVs, and the radios. That were one of the sources that they would be targeted. So in a discussion, so mpox was generally perceived as a low-risk event by these respondents. This differs from other studies that have been done on this in other developed countries. You can remember that I think last year or last 2 years, there was a huge monkeypox outbreak in Europe, and they know that this was a high risk, a disease that was high risk to them. So it is worrisome for us because when you perceive monkeypox as a low awareness, and this can be as a result of there are so many unknowns about monkeypox. If you are listening to the discussion upstairs, there are still very lot that is not known about the mode of transmission. The older knowledge we had was spillover from animals, but we know that we are now seeing monkeypox even in places that have not come in contact with animals. So this is important for us because we know that individual cues to action, that is the belief system, that they are affected by the degree of perception of threat of what they. So them believing that it was not a serious event was a concern for us. And we also saw that the mpox information were not from the hospitals. They were needed to caption on the social media in order to get this group. So in the way of discussion, we also noticed the underage. Underage among respondents could likely dispose that there might be a child of molestation, there might be a form of molestation or child abuse, because when we say the underage, being in this class of persons is a concern for us. And the young population that belong to this group is something that we also need. We think that this is an issue because the young population, they are mobile. They are about to move around. They are about to interact more. They are about to spread if there is any kind of disease spread among this group. And we also took notice of the urbanization and social integration. So most of these cases will have occurring in the centers, which is the urban centers. And we liken this to be the urbanization and social integration that are really going into these places that we may not have known. And it's also important for us to point out that heterosexuality and the poor social habit among this group that are likely to increase disease transmission. If perchance mpox occurs in this group, there is a high likely chance that it will cause an outbreak and it will spread rapidly. So in our recommendations, we talk with the social mobilization pillar of the EOC in order to target the young population. We also talked to the NGOs that are in charge of counseling for children. We also talk to them so that we will always look out for when some of these young people come out and we find that they have symptoms of mpox, which we are not used to. So we also advocated for improved behavioral change to support the risk perception of mpox. And we also targeted that social medias should be concentrated in some of these, driving the risk communication for some of these groups. So the intensification activities of HIV, when we look at the result, we found out that most of them still do not know their HIV status. And this is also worrisome for us because we already know, most of us know here, that about 20 to 30% of HIV transmission is through this group of MSM. So this was important for us that we had to communicate with the HIV sector, so for them to get in touch with some of these groups who happen to open up about how to prevent occurrence of disease transmission. Thank you. So these are some of my acknowledgements, the MFLT program, the African and the Rivers State Ministry of Health. Thank you very much.
Thank you, Hastings. I think because since we have only one microphone for the room, I suggest that we take the questions now before you come down. So do we have any questions for Hastings? Yeah.
Hi, Hastings. Thank you very much for your presentation. I have two quick questions. By the way, I'm Chucheko from South Africa. The first question that I have is that since MSM is banned in Nigeria, I'm curious to know what was the response rate from the participants, because I'm assuming that some might be a bit afraid to participate in the study. And the second question was the age group of 10 to 24. What justified the selection of this age group? The age group of your study, what justified the selection of this age group? Thank you.
Do you have another question? You can take one more. Please introduce yourself and maybe where you come from, because maybe Hastings would like to catch up with you just in case maybe it doesn't address all your issues. Thank you.
Yes, thank you very much. I'm Andrew from Sierra Leone. Thank you for the presentation again. So in your background or the introduction, you told us that 85% or so of prevalence of mpox has been among people who practice MSM. I wanted to know what is the situation of your country? What's the prevalence? Has there been any outbreak of such recorded in Nigeria to show that they could be at risk? Or is it that the prevalence is actually high in other districts to show that they could be at risk in your district or your place of study? And I saw that your recommendations were not targeted to the group you actually conducted your study in. Rather, it was generalized. Why did you choose to look at the general populace instead of the people who are practicing the MSM?
Okay. So thank you for the questions. It means that we were all here. So the first question was the response rate for MSM. So this is a very big study that I had to involve a lot of, it's a very big study that I had to involve a lot of people. I'm trying to look at you. Okay, so the response rate we are much. We had about 500 respondents. So we are coming from a settings where we never knew that there were MSM cases within our community to a place where we have about 500 respondents. So with the response rate, we are much to the best of our abilities from knowing that this group, we never know they existed, and we were able to get about 500. So we had enough response rate because in the Ministry of Health, they felt that they needed to align with us since they know that this was banned. So when we carried out this study to know what was happening in our society, we had a very large response rate. And that was why you were able to see the different ages that were accommodated in that response. Now, the second question is, what is the justification of the age group? So maybe if I didn't get to where, it was an open questionnaire where the different age groups came up and responded. We were not targeting at any age group. So there were even a point in time during my studies where there were concerns, should I bring in people that are underage? But I felt that I needed to bring up every age group that were represented in this presentation. So we never targeted at any age group. It was open, and that's why we had the underage, we had the teenagers, and we have the older men that were 65 years and above. So for the second question, thank you very much for your question. So you said 85% of MPOX cases. So yes, if you use your Google and check out studies now with me here, it is stated that 85%, wherever studies have been conducted, has been about 85%. But we are working with a clause in Nigeria. It is banned, and it has a 14 years life imprisonment if caught. So we may not be able to establish the MPOX, the prevalence of MPOX among MSM in Nigeria. But that was why I said, but we have recorded cases of MPOX, which we later did investigation, and we find out that this person was heterosexual. He was an MSM. So I may not be able to tell you the prevalence of MPOX in MSM, but I'm able to tell you here that there are cases of MPOX among MSM in Nigeria, but I will not be able to say the prevalence. So you said the recommendations were not targeted. So this is where the politics in research comes in. The ban on MPOX and this group means that you don't offer them interventions. Let me get to explain that. You don't offer them interventions, you don't do anything extra for them. But we are working under the guidance that we are working on MPOX. And sometimes we can also cover ourselves that we are working on HIV. So we might not have targeted interventions for them, but what we are targeting is the social structures, the HIV groups, the health facilities. If we happen to pick up any of these cases, let us work with them and prevent disease transmission with the mindset that we are working against MPOX. So we are not allowed to provide a special intervention for this group because it means that we are habiting this group and we are providing solutions for this group, and it's also banned for some of us. Thank you very much.
Good afternoon. My name is Sikwata Sarafina from Kenya. My question is just around the age distribution. When you're doing the age groups, we saw that the 25 to 44 seem to have the highest numbers. But looking at the band, it seems to be a broader band. Could that have been a biased interpretation? Because it's a larger band compared to the other age groups that you had selected. They are not equal.
Okay, I will agree with you that during study, if you don't do the age distribution, if you don't provide an average age distribution, you are going to skew the result. But what we try to look at, when we were writing our concept note, we never ever felt that we will get all the age groups in this group. So it was when our results started coming in that now came in that we now found out that some of these age groups were concentrated on it. So I accept your advice or your comment about trying to maybe next time in this kind, if we are going to work with this group, we try to make the age distribution even. But we never expected that we were going to get age groups that were smaller than what we got. Thank you very much.
Yeah. Let's applaud Chinendu once again. Yeah, thank you. See, that is what makes the Nigerians very, very famous in Nairobi and Kenya for all the good reasons. That's why the name Chinendo is very, very common here. It's again for all the good reasons. Well done. So let us move on to the HIV now, and the next presenter will be Helen Mulalia, who will present to us on determination of recency of newly diagnosed HIV cases in Malindi Hospital. Helen, the floor is yours. You have 10 minutes to give us your presentation.
Good afternoon. Good afternoon. Good afternoon. This is Helen Masila. I'll be presenting you on the determination of recency of newly diagnosed HIV cases at Malindi Sub-County Hospital for the year 20. Oh, sorry. Excuse me. Sorry for that. Sorry for that interruption. I'm Helen Masila. I'll be presenting you on the determination of newly diagnosed HIV cases at Malindi for the year 2021 to the year 2023. I'm a Kenyan FLTP, that is the advanced. On introduction, globally, 38.4 million people are living with HIV, and among them, we had 1.5 million newly infections. In Kenya, for the HIV burden in Kenya, the prevalence is at 4.9%, whereby 1.3 million people are living with HIV in Kenya. That is according to KenFIA of the year 2018. The HIV recency of Malindi is unknown. Therefore, we wanted to know what are these newly and long-term infections at Malindi Sub-County Hospital. For the description of the surveillance system, a recent HIV infection was defined as the one that was acquired within the past 12 months. And these are the eligibility criteria. The individual should be newly diagnosed HIV positive, should also be a voluntary exercise whereby someone has to consent to participate in the system, and also they should be 15 years and above, among others. So for the recency testing, this is basically how the test appears in the laboratory for the testing, whereby the long term appears as 3 lines, as you can see. For the recent one, it will appear with the 2 lines, where the negative will have 1 line, which is a rare case. But again, for the recent HIV testing, to do better reclassification, we do a very low testing so that we can be sure that these are really true recent cases. And this is basically the flow, whereby the first entry is at HTS, whereby this individual, one should be newly HIV positive diagnosed and should be 15 years and above. And the next step is that this HTS provider will have to consent this particular client. If the person consents for the surveillance of HTS of HIV recency, the HIV provider will address that, will fill the form and take all this form to the phlebotomist, whereby this client will undergo the blood draw and finally taken to the laboratory for testing, and of course data entry. So what is the importance of this? Just a snapshot. This is whereby the recent HIV testing will have, you're able to take the recent HIV cases in terms of time, place, and person, and also identify the transmission hotspots, and this will enhance targeted HIV prevention. So the objectives, so one was to determine the proportion of recent HIV infections, to inform the targeted HIV prevention interventions, and to identify the geographic areas associated with recent HIV infection. Methodology, as you can see on the right, this is me doing data collection and data abstraction at the facility. In the registers, the period of September 1st up to March 2023, the variables that were collected were age, sex, marital status, rapid test for HIV infection, and the viral load results. So data analysis, we summarized in frequency and proportion, and also we also did the strength of association to see whether these social demographics are associated with the HIV recency. So what were the results? For the variables we had the age, whereby the age above 30 years were the majority at 72.2%. Then the sex, female were majority at 59.8%. For the marital status, the unmarried were the majority at 52.1%, while for the result for recency, the long-term were majority at 94.7%. Test for recent HIV infections, as I told you earlier that for anyone to undergo this recent surveillance exercise, he or she should be newly HIV positive diagnosed and should be 15 years and above. So that's why during data abstraction of the registers, we had 169 adults who were HIV positive, and among them, when the test was done for recent testing, 9 of them were recent and 160 were long-term. As I told you earlier, to be sure that these are truly new recent, we do viral load to be able to reclassify further. And among the 9 that were done for viral load, 3 of them had a viral load above 1,000. And as you can see, the final classification, we had 9 new recent HIV infection and 166 were long-term. For the factors associated with HIV recency, we had 3 factors as shown there. For the age group below 30 years, they were 3.5 times more likely to have new HIV compared to the age group above 30 years. For the male had 3.2 times more likely to get new HIV, to be recently infected with HIV compared to female. And lastly, marital status. For the married, they were 1.4 times more likely to have new HIV, to be newly diagnosed with HIV in comparison to the unmarried. And conclusion, majority of the new diagnosed, as I've highlighted above, were long-term, and the age, sex, and marital status were found to be associated with the new HIV infection, but there was no statistical significance among those variables. Our recommendation, we had 2 recommendations. One, integrating the recent HIV testing to the routine testing in Kenya, and going ahead to do the viral load. Remember, the surveillance was that we only do viral load for those who turn to be HIV recent. But again, looking at the way data has shown us, we really had questions. What could be the characteristics of these individuals who are long-term? So we recommend that to be able to answer some of these questions that we are still having, we go ahead and start doing a viral load for all of them. That is both long-term and also those who test recent infection. And for the public health action, we also had the same public health action of integrating this recency into the normal HTA service in Kenya. These are some of the pictures and images we took during our discussion with the stakeholders on how to enhance this surveillance and normal routine testing in our hospitals, just to ensure that a lot of protocols are not going to be involved. And as you know that all this surveillance is protocol based, whereby there's really need a lot of support, both from programs and the government of Kenya. So I acknowledge the aforementioned institutions And these are part of my references. Thank you.
Thank you very much, Helen, for that highlight about the importance of the HTS to be incorporated, the recency testing, incorporation into the normal HTS services. Do you have questions for Helen? We have time for 2 or 3 questions. Yeah. Introduce yourself, please.
Thank you, Helen, for the interesting presentation. I just want a clarification. In your flow, if I recall, the number you said were recently infected was 6. But in your 2x2 table, I saw 9. So could you just clarify why you went with 9 versus the 6 in your flow? Thank you. My name is Uzoma Obunda from Nigeria.
Okay, thank you. Maybe if I can try to answer that question, is that among the 169 who consented for the surveillance of HIV recency, we had 9 who turned to be HIV resident. And if you remember very well, I said that whenever someone tests resident, we do further reclassification by doing a viral load testing, whereby for anyone who turns out to have a viral load above 1,000, we say these are the truly newly diagnosed. And that's why we had 9 as resident, but when we went ahead to do a viral load testing, 3 of them turned to have a viral load which is above 1,000, so we reclassified them as true recent HIV infection. And the 6 who turned out to have a viral load below 1,000, they flipped back to the original 160. That's why we have 166, a long-term, the final report, and 3 only true recent. So out of 169, only 3 were true recent HIV-infected individuals. Thank you.
Do you have any other question? Yes, please.
Thank you. My name is Nangoma from Zambia. I have a question on your table. I saw you only presented the odds ratio. I don't know if it was adjusted or unadjusted, and how you based your recommendation based on that. Thank you.
Okay, thank you, Nangoma. For the table, yes, I only presented the odd ratio, that the crude odd ratio. I was only doing the comparison between those 2 variables. It's only bivariate analysis. I did not go ahead to do multivariate analysis because the odd ratio, the p-value was above 0.05. So I could not go ahead and do the adjusted odd ratio. That's why I left it at only crude odd ratio, whereby I was only doing comparing and seeing at the association only. I only worked with the association only, but there was no significance. Thank you.
Thank you. I will try to speak in English. My name is Dr. Kasongo Jolie. I'm the RA of Guinea. And I want us to say what is your study and can you, I don't know what I can say. In French, I can speak in French, yes. OK, quelle était ton étude et quelle était l'exposition et quelle était, qu'est-ce que tu as considéré comme...
And what were the salient points of your presentation? Because you talked of risk. Would you please clarify? Because I hear of an old ratio, but when I look at your methods, I didn't pick what you were bringing out to point out the old ratio. Would she come again? Because the presenter was not with her headphone on.
Kindly repeat the question.
I will now ask my question in French. I wish to know what was the type of your study? Because at the end of it, I got the feeling that you had, you were mentioning risk, but in everything you did for the study as a methodology, I didn't see what led to the conclusion. You talked about risks at the end. Whatever it was associated to the recency of HIV. So I needed to know why it was women who were predominant with the HIV. Would you please explain what would really be attributed to that, what that would be attributed to?
Yes, according to my study, that was the study was basically secondary data review from the registers, as I have informed earlier, and we are looking at actually we are looking at what are these new HIV infections, where are we getting them from, and as you all know that in every disease we are trying to address, there are risk factors that are within that particular kind of a disease we are trying to address. So for HIV, we also not leaving it behind when it comes to risk, looking at the demographic that we had. It's just that we only had a few risk factors, and these are from the demographic variables that we studied. And yes, in the end, we could see there's an association that there was no statistical significance among the variables that were studied. But again, there was an association whereby we could, when we ran through the bivariate analysis, we could see that there are some who are likely to get this infection in comparison to the other variable. And looking at the age group as well, you could see that those who are below 30 years, they were likely to have this recent infection compared to those who are older. So that's why we are trying to say that in every element we try to study, there are risk factors involved in it. And this being a surveillance, whereby we also want to, especially for the countries like Kenya, who are heading toward the epidemic control, want to be sure that we are only dealing with a few cases of HIV, and that's why we had to do this surveillance. However, now the data we have in our server, or rather what we already have, is that the report we have is that what we expected is not what we have gotten. What the research question we had at the initial is not what we are getting right now. And that's why we are saying that we're asking ourselves, looking at the population, looking at the data we have just shared, are we dealing with people who are already maybe on medication and maybe we are not aware of them? Are we not, like, if we have a method of doing like verification of this individual we register, could we believe the people who are doing like a retesting, taking drugs, lost to follow up, they come back again? We are not sure that, like, if a client tells you that have never been tested, you as a healthcare worker, you do not have a go ahead to do like verification. You just have to rely on what we have. And that's why we are saying that this data is giving us a report that is giving us a report which is opposite of what we really expected. Because when talking about epidemic control, we expect the cases, that is the incidences, to go down. But looking at what we have right now, like this long term, they are newly, because the study is all about the newly diagnosed. So when we have this, they are new diagnosed. But again, they are majority. And of course, when you see long term, are they really people living with HIV unknowingly, or are we just having testing people who are on HIV, maybe they have lost follow-up, and then we start enrolling them again to the HIV testing? We become like asking so many questions. And that way we want to go ahead and do like a viral load. We try to characterize these individuals to be able to answer some of these questions very well. Thank you
very much. Thank you very much, Helen. Join me in appreciating Helen as she comes down. Thank you very much for that talk, and I think these are discussions that can still continue outside of this room. And now to conclude for us this session, we have a presentation from Uganda. So we have Winnie from Uganda who will be presenting to us the willingness to take pre-exposure prophylaxis among the high-risk young men. So that is the Ugandan team way of doing it, yeah? So it looks like Mombasa is doing good to some people here. So let us continue that spirit. Winnie, the floor is yours. You have 10 minutes.
Thank you. Hi, everyone. My name is Winnie Agwang, and I'm going to present to you a study on willingness to take pre-exposure prophylaxis among high-risk young men aged 10 to 24 years in Masai fishing community, Jinja district in Uganda. Those are my co-authors, and the presentation will follow the following outline. Just to show you where Uganda is, we are just neighbors to Kenya, a stone throw away. And this is where the study site is. It's on Lake Victoria in Jinja district. That is Masese fishing community. That's how the community looks like. It's a very busy place. People are doing all sorts of economic activities, fishing, other businesses, casual labor, with the biggest business being sex work. Between 2010 and 2020, new HIV infections have reduced by 31%, from 2.1 million to 1.5 million, and HIV-related deaths have been reduced by 47%, and we can attribute this to the available prevention strategies, including pre-exposure prophylaxis, which I'll be calling PrEP going forward. So PrEP is a self-controlled prevention tool that has been demonstrated by a number of studies to be effective in preventing HIV acquisition among high-risk populations. In Uganda, fishing communities are characterized as very high-risk populations with a prevalence of 37% of HIV. This is mainly due to the poor access to health care, the high mobility of the fishing communities, and the high rate of risky sexual activities, where sex work is the order of the day, and people tend to pay more for unprotected sex compared to the protected sex. We did willingness among this population because it has been shown that PrEP helps prevent HIV, but there is scanty evidence of PrEP use among the fishing community, and to be more specific, among the adolescent boys and young men. So that's why we chose the age group of 10 to 24. So our objective was to examine the willingness of the adolescents 18 to 24 to take PrEP and their understanding of PrEP in the context of HIV prevention, Masai fishing community. We use the theoretical model, the health belief model, as our guiding framework. So that's how the health belief model looks like. We have modifying factors, we have the individual beliefs, and we have the action, which is willingness to take pre-exposure prophylaxis. So how did we achieve our objective? The study was done in Masai fishing community in Jinja district. The study population was adolescent boys, who we call young men, 18 to 24 years, who had 2 or more concurrent sexual partners with inconsistent or no condom use. It was a mixed method study where we used both quantitative and qualitative methods of data collection. For the quantitative arm, we had 479 young men. And then for the qualitative, we had 32 participants who we used focus group discussions. These are stratified according to age, and we had 4 focus group discussions. The sample size was determined using the formula by Kish, with our p-value being 53.5%, and our maximum allowed error was 5%. For the data collection and sampling procedures, for the quantitative arm, we use a convenience sampling, while for the qualitative arm, we use a purposive sampling. We use convenience sampling because of the way of life of the people in the fishing community. They are highly mobile, so you find that today the person is here and tomorrow they are not there. And then also their schedule keeps varying from time to time. During the day, most of them are actually asleep, and then during the night, they're in the waters fishing. So the best method we could come up with was convenience sampling. And for the qualitative, and we used purposive because we wanted to have those who did not have any prior knowledge during the quantitative exposure, because they would be biased when answering during the focus group discussions. So for data analysis, we used thematic content analysis for the qualitative data we collected. And for the quantitative, we did a descriptive analysis of the variables. We did bivariate analysis, and then we used a modified Poisson regression to determine the factors, because our outcome was above 10%. The focus group discussions had 6 to 10 participants. They were audio recorded and later translated for analysis. We also got ethical clearance from the Review Ethical Committee. And then also we had permission from the Ginger District Health Office. And then also we had permission from the Masese Fishing Community. And for the participants, we made sure we got their consent for those who are above 18. And for the non-emancipated minors, we got their assent and consent from their parents. So those are our findings. The mean age of our participants was 20.9 with an SD of 2.5. A majority of them were single, they were Muslims, and they attend a secondary level of education. But when we looked at the sexual behavior, we found that most of them had more than two sexual partners, with majority of them having 3 sexual partners, with an interquartile range of 2 to 5. Above 50% had 2 to 4 sexual partners. More than half of the participants reported inconsistent condom use, and 40.7 did not use condoms at all because they felt it brought bad luck to them if they used it. So for our willingness, we found that 86.4% were willing to use PrEP. And when we looked at the different attributes of PrEP, we found that majority of them were willing to pay for PrEP, and they were more willing to take PrEP if it was in oral form. They had information available with evidence that PrEP works. However, if they faced stigma, the willingness dropped. And for the factors, we found that those who thought that a very high risk of HIV acquisition, they were more willing to take PrEP, and the likelihood to take PrEP increased with the ability to access it and with information that it was safe. However, when we looked at the marital status, we found that people who are single were less likely to take PrEP. For our qualitative findings, 3 major themes emerged. Young men describing PrEP as a drug used for HIV prevention, that PrEP would also lead to an increase in sexual immorality and affect their libido, and also young men are willing to recommend PrEP to other eligible users. So this is a quote for the first theme. I heard that these tablets, that when they give you these tablets, you take them and don't get the virus. I don't know how, and I don't know how you'd use those tablets. So they know that it prevents HIV, but they don't know how it works or how it's taken. And for the second theme, but I still think that they are, as they're playing a role of reducing HIV on one hand, they're going to cause something else. I'm going to make that girl pregnant. They're going to increase the population at the landing site because this girl is going to get pregnant since sex is already the end of the day in the landing site. And then also the second quote for the libido, they want to reduce our sexual power. They, that is the PrEP, contradict with some tablets that increase our libido. So that's the quote for the third theme, where the person responded that they can inform all those around them to take the PrEP because they don't want them to get into trouble of taking ARVs. Our study had some limitations. We had some bit of social desirability noted in the study, but we tried to work around this by creating a very conducive environment and making sure we did the study, we administered the questionnaires in privacy. And also we used convenience sampling, which could have introduced bias to the study. But we try to also control for this by making the sample size as big as possible and making sure that we sampled from every zone of the fishing site. In conclusion, we believe that given the high willingness to take PrEP among young men, they should be targeted for HIV prevention, but programs and implementers should target the single, make PrEP available, as well as ensure that information is available on the safety of PrEP to demystify the myths and misconceptions which are associated with PrEP, but also carry out sensitization. That's the take-home message. PrEP is suitable for HIV prevention. We should target the groups that have demonstrated low willingness, but also the health belief model is a very good model that can help you understand uptake of prevention strategies. These are our references. I would like to acknowledge the given institutions and persons who had a very big role to play in the study. That is the end. For any information and if you need to network, kindly reach out. Thank you.
Thank you. Thank you, Winnie, for closing for us this session with that exciting presentation. I'm sure you could have some 2 or so questions for Winnie.
Thank you again. My name is Nangoma. Thank you for the study. It's very interesting. I just have 2 questions. I was looking at the age group of 10 years, and that is maybe less than 16. I'm speaking on the perspective of my country, where if we have participants less than 15, there's consent from parents. So I don't know how you overcome that and why you chose such an early age group. So I want to know from Uganda, what is your age of first sexual intercourse, especially amongst these young men? Thank you.
Thank you so much. I'm Dr. Chala Abalo Ambala from Guinea. And my question is about the recruitment of young for your study. According to what you have presented, the use of condom among young was a critical criteria for the recruitment for your study. So how have you been able to assess with accuracy the use of condom among young? Which tool have you used? Thank you so much.
Okay, thank you so much, colleague. I just have a comment and 2 questions. The comment that I have is on your slide number 13. I realized that you had a lot of information or a lot of data that you indicated, but we couldn't see that information on your slides. My question is on, did you have any non-responses? And if you had, at what proportion? Right. And my second question is on the qualitative data. What methods did you use to measure the qualitative data? Thank you.
Okay. All right, thank you very much for the questions. I will start with a question of assent for the minors. Okay, our study had both in Uganda or in any study, we have emancipated minors. In Uganda, adulthood starts from 18. Anyone above 18 is an adult, so you can answer the questions. You can participate in a study minors involving your parents. But if you're below 18, then we have to seek permission from your parents first, as well as the study participant. And in the fishing communities, we have both emancipated and non-emancipated minors. Emancipated minors are those who maybe live on their own and are parents already. So those ones you don't need to seek, again, permission from their parents because they're already living on their own, taking care of themselves. Some are parents to their siblings. But for the non-emancipated minors who still live with their guardians or relatives, I mentioned it that we sought for permission from their parents. So we had to first go to the parent, talk to the parent, would like your son to participate in our study, are you okay with it? So if they're okay with it, then we give them a consent form to sign. And then for the child, we'll also ask them, do you want to participate in the study? If they're okay with it, then they also sign. So we need to get permission from both the parent and the child to participate in the study before they can proceed. But if any of them says no, then we can't proceed with that participant. The next question was on use of condom as our eligibility criteria. Yes, it was for those who had inconsistent or no condom use. How we determined this, there was no accurate way of determining this. So what we did, we went by word of mouth, unfortunately. Could be a limitation for the study because of the social desirability that I talked about. But you try to make them as comfortable as possible. You try to create rapport with them. Actually, they're very friendly people. So we try to create rapport with them, and we believe that all the people included in the study were eligible for the study. So there was no accurate way of determining if they used the condom or not. For the non-response, unfortunately, we didn't get any non-response. Probably because we did this sampling with the help of the village health teams. In Uganda, we have what we call village health teams. They're responsible for a given village. So they handle the health issues of that village, so they are known. So when you go to a household with this person, they explain to the person what you're doing, the benefit of the study. So we didn't really have any non-response in our study. And also maybe because we use the convenience sampling. Because I come to you, I tell you about the study, are you willing to participate? If you are willing to participate, then we enroll you in the study. If you're not, then we leave you out. So we didn't have any sampling frame or something like that. And then for the qualitative data, I really didn't understand the question. I don't know how you wanted us to determine the accuracy of the data. Because I believe for qualitative data, we did focus group discussions where we used audio recording, we sought permission from them, and then we did translation and transcript because it was in Lusoga, the main language at the landing site. So we did translation, then we did transcription, and then we did the analysis using thematic content analysis. Thank you very much.
Thank you. Thank you. Let's give a loud of applause to Winnie as she comes down. And I think you can still consult more, especially because she has given her contacts. So we wish to come to an end of this very exciting afternoon session where we've had presentations on the importance of surveillance of hepatitis B and the importance of accurate data collection. We also had on mpox among men living with men, men having sex with men, and the importance of having more data coming from the health institutions. And we also had the importance of integrating recency testing in normal HTS services. And we've finished with Winnie presenting to us the willingness of PrEP uptake among the high-risk populations. And so that brings us to the end of this scientific presentation. Allow me to, let's join hands in thanking and appreciating all the very good presenters who have kept us busy this afternoon. And let us appreciate ourselves for being awake. Thank you very much. And so that we can be on time for the cultural night, I'm being reminded to remind you that the cultural night is tonight. So you're being invited to the main plenary hall, Pride in Paradise here. That is the plenary hall, where we've been having our plenary sessions at 7 p.m. so that you can be able to sample the Kenyan culture. So expect to sample a lot of Kenyan food, Kenyan music, Kenyan dancing, Kenyan dress, and everything that comes with Kenya. They normally say that coming to Mombasa is very easy, but getting out is very difficult. So you need to be very careful. But that will not happen around Serena or around here. It is if you go towards Lindi, you'll find it very difficult to get out of Mombasa. So we hope to see you there, and please, the dress code is Kenyan national colors, so you can come in black, red, white, and green, or combination of all of them. Yeah? So you're most welcome, and thank you so much for being very attentive. I wish you a good evening. See you at the cultural night.